This series of tapes is a major consultation for the practicing psychiatrist with a number of outstanding specialists and researchers in the field. The discussions will follow the APA guidelines on depression and are really meant to develop a lively interchange between the listener and the speakers. And I hope that every listener will understand that while we won't be totally comprehensive, we're going to make it a fun experience and an opportunity for you to see how much controversy there still is about a diagnosis that we take for granted.
I can't cope with this depression because I have no control.
It decides when it wants to hit me, and that's all there is to it.
I got no energy anymore. I can't even think clear, and I just don't care about things like I used to.
Like I'm sunk into a big, deep hole. I want to sleep forever, but I can't.
One constant flow. Loss after loss.
We have gathered here a number of colleagues who have special expertise in various aspects of depression. They are William Dubin, Professor of Psychiatry at Temple University and Acting Medical Director at the Belmont Center for Comprehensive Treatment, both in Philadelphia.
The biggest problem, the difficulty I have and my colleagues do, again, falls with these group of patients who have, quote, personality disorders. And I think sometimes we do our patients a disservice by jumping too quickly that this is biologic, rather than kind of taking more of the middle ground. No cardiologist would talk to a patient who has angina, not mention lifestyle and bring in all these other issues. So while that is happening in medicine and they're sort of moving to more...
Glenn Gabbard, Vice President for Adult Services at the Menninger Clinic and Director of Menninger's Memorial Hospital, as well as Clinical Professor of Psychiatry at the University of Kansas School of Medicine, and Training and Supervising Analyst at Topeka Institute for Psychoanalysis in Kansas.
I think what we're getting at here is a fundamental conceptual issue of what is depression all about. I think that we psychiatrists make far too sharp a distinction between psychotherapy and pharmacotherapy.
Tana Grady, Assistant Professor in Psychiatry and the Director of Residency Education at Duke University Medical Center in Durham, North Carolina.
Of the culture that you're speaking about, to look at the individual patient as an individual, be sensitive to the potential impact of cultural issues, but not to impose your own idea of what should be the case.
James L. Griffith, Director of Psychiatry Residency Training and Vice Chairman at the University of Mississippi School of Medicine in Jackson.
I guess our tone of discussion would give it that much of this choice lies with our patients. Things I'm not sure we can survive as a field that only can work with physiology.
James W. Jefferson, Distinguished Senior Scientist at the Dean Foundation for Health Research and Education and Clinical Professor of Psychiatry at the University of Wisconsin's Medical School in Madison.
But be that as it may, you want an adequate trial of drug. You want to be sure you really are treating depression and you've recognized all the comorbid or complicating features. And I agree with you, once you get beyond an augmentation strategy or two, this becomes the art of psychiatry rather than the science.
Arnold E. Merriam, Associate Professor of Psychiatry and Neurology at Albert Einstein College of Medicine in New York City, and its Director of the Department of Psychiatry in the Division of Neuropsychiatry.
The APA wanted to put itself on record coming out with APA guidelines. In the process of creating these, we corresponded with hundreds of psychiatrists across the United States. It's very, very hard to reduce treatment to an algorithm. After having put in so much work into preparing these, I would regard managed care's guidelines, if they are more specific than this, as being illegitimate, because this really represents the consensus of 1993 psychiatry.
Rodrigo A. Munoz, Professor of Clinical Psychiatry at the University of California at San Diego.
Now, I am not saying that I am describing a formal study. I am saying that a lot of adolescents who do not feel very well about themselves, who do not have a sense of identity, who do not belong to the general community, are violent. Eventually, you end up in the largest psychiatric facility in the country, which is the Los Angeles County Jail.
Elliot Rickelson, Director of Research at the Mayo Clinic in Jacksonville, Florida, and Professor of Psychiatry and Pharmacology at Mayo Medical School in Rochester, Minnesota.
This individual has a decrement in terms of functioning. They're not quite able to do what they were doing before. They're not working as well. Any indication to me that their functioning has been impaired, no matter how little, that's when I go ahead and use an antidepressant.
Robert Taylor Seagraves, professor of psychiatry at Case Western Reserve University and interim chairperson of the Department of Psychiatry, Metro Health Medical Center in Cleveland, Ohio.
You have to look at the social context of patients, and obviously the main thing in terms of the newer antidepressants is the SSRIs have a lot of anorgasmia associated with them. I don't think we really know yet how frequently. I think this is a major problem with SSRIs, and I don't think we ought to put a patient on those without warning them.
Edmund C. Settle, Jr., in private practice in Charleston, West Virginia, and clinical professor of psychiatry at West Virginia University.
To get off of your butt and go do a neurologic exam. I would say the majority of these cases that I've picked up is when I've walked over and picked up my reflex hammer and found asymmetric reflexes or upgoing toes. And in fact, one of I think the best clinical laws of psychiatry is thou shalt never miss the upgoing toe.
Myrna M. Weissman, professor of psychiatry and epidemiology in psychiatry at the College of Physicians and Surgeons at Columbia University in New York, and chief of the department in clinical genetic epidemiology at New York State Psychiatric Institute.
One of the things I hope we say in this tape is that it's not useful to divide depressions into biological and non-biological, because whether or not the patient who's getting medication gets psychotherapy, they need to have some kind of monitoring.
I'm Paul J. Fink, Associate Vice President at the Albert Einstein Healthcare Network in Philadelphia and Professor of Psychiatry at Temple University School of Medicine here in Philadelphia. This discussion started with a news item that most psychiatrists had obviously thought about at the time that it occurred. And that was the tragic suicide of Vincent Foster, President Clinton's aide. While this is, of course, a hypothetical discussion because none of us have examined him, and all we really knew about his situation was what we read in the press, it seemed to be a good way to get a feeling of the experiential side of this issue. Myrna Weissman led off.
I've thought a lot about that because I think it's an example of the problem in the treatment of depression in this country. And if he had called his family doctor and said, "I'm having chest pains," there would have been a great deal of alert. When it was depression, it was kept quiet.
The heart patient may seek help because he knows something is wrong with him. The depressed patient, to the contrary, may withdraw and decide that he is not worth any attention or any care.
If you're depressed, there's something characterologically wrong.
What was striking to me is all the editorial pieces were sort of looking at what external factors in the Washington environment killed Vince Foster, not what illness did he have that led to an outcome of suicide. I have the feeling that the press really does not understand that depression is an illness and that it's something that has suicide as an outcome in 15% of the cases.
And I also wonder what role gender difference had to play in terms of the expectation that he should be able to handle all these things and not have to look at family issues or job issues. Somehow all these environmental stressors played a role in it, and women tend to be more likely to have, in some ways, better treatment in that other issues are looked at.
You think that because we assume that men have to express their machoism that we're not going to address the softer issues?
I think the issue is our society values stoicism. We like stoic people. We like people who, quote, hang tough, who can show their toughness. We don't like whiners, wimps, complainers. And I think the men are from the day we're born, we're taught, this is how we have to be. And I think that really works against someone who has a depressive episode coming in and reporting, I'm depressed, I feel terrible.
But also relationship system. When you see a family system that is organized in such a way that one very responsible person tends not to bring up their problems.
I think the family doctor is really key in the detection of people who don't go around talking about their illness, but they may talk about it to the family doctor. I think that probably we can do a lot more in training about the simple questions one needs to ask to elucidate that kind of information.
We talk about educating the doctors, but also how do we educate the patients? And the reason I say that is because I lecture to a lot of primary care physicians and know a lot of them, and talk about the whole issue of recognizing depression. And I'm sure everybody in this room has heard these anecdotes that they say to a patient, I think you're depressed, you need to be on an antidepressant. The patient often will become antagonized by this statement and leave practice and say, well, I'm going to see another doctor. You don't know what you're talking about. I'm not depressed. So I think having the primary care physician recognize that depression is one issue. The second issue, how do we get the patients to recognize it and accept it?
And I believe it's a major area for therapeutic and preventive efforts. If we think that somebody who is 85 years of age probably was not aware when he was 40 or 50 or 60 of the presence and the importance of depression. But there seems to be an epidemic of depression among older people and certainly an epidemic of suicide.
Is that in the elderly Hispanic, or is that in all groups?
All.
Lethality is obviously an important subject when we're talking about depression and suicide.
I think we also have to recognize that suicide is inherently unpredictable in some cases. We can certainly hone our skills better and save some people, but there are some people that do not give sufficient clues, and they're very, very difficult to save.
Glenn?
Just to pick up on what Arnie said, there is at least one study that was done by Goldstein et al., where they studied 1,906 inpatients with affective disorder, and they developed a statistical model that incorporated all the known risk factors that would predict suicide. Using this sophisticated statistical model, they were unable to predict a single suicide with it. So we have to acknowledge, somewhat humbly, that we have limits to what we can predict.
If you just look at what we know are risk factors, there's a heck of a lot more patients who have the risk factors than who actually complete a suicide, and you're really in a bind. It's like, I think it was Paul Samuelson's quote about economists, that they've accurately predicted 14 of the last 3 recessions. You know,
I don't know what's wrong. I got no energy anymore. I can't even think clear, and I just don't care about things like I used to.
You know, I think the questions are important, and they fall into some groups. I think the vegetative signs, that is the lack of psychomotor attention abilities, constipation, the waking up early and looking at the walls for a couple of hours.
Reverse polarity, excessive sleep, excessive appetite, have a sense of leaden paralysis or severe muscular fatigue and inertness. And then there are other individuals who have severe anxiety symptoms.
And certainly the low self-esteem, the feelings of helplessness, the externalization and blaming on others. When you see 15-pound weight loss, that means anorexia, that means most likely insomnia and other vegetative signs.
Also, what you call a role transition. Change jobs, moved, change in position. And that's one of the typical areas where you find depression occurring, especially in someone who's vulnerable. Also, you'd want to know the age of onset of the diagnosis. I suspect a first episode at age 47 happens, but it's unusual.
Additionally, it might be useful to know if he had a depressed parent, what impact that had on him growing up, and what was the developmental environment like.
Well, if there was a family history of depression or maybe bipolar illness, that would suggest increased risk, and it would confirm the seriousness of the diagnosis. Suicide and suicide attempts are very contagious, and I'd want to know not only about the family history, the biological relatives, but friends, because you do see clusters.
There's also the issues of the psychological questions: guilt, worthlessness, helplessness, hopelessness, powerlessness. Questions that reveal those kinds of feelings.
Do you feel life is not worth living? Do you ever wish you were dead? Are you thinking about suicide? Are you having problems sleeping? And then what kind of problems? Have you lost interest in sex and in your family? If those, maybe 8 or 10 questions are all you ask, and then the patient says yes to at least half of them, it becomes a more real phenomena. And I think that's where the education needs to be in. What are the questions that you ask?
All of these things are critical to making the diagnosis, and it's not just family physicians. And it's psychiatrists as well who may not have the ability to say, look, here are my findings, with enough conviction that the patient doesn't go looking for some other magical approach.
The other risk factor I wanted to point out is the delusional aspects, psychotic aspects in depression. Delusions of guilt or paranoid delusions where an individual feels victimized and feels they might as well get rid of themselves because otherwise they're not going to be getting rid of by another party.
Mm-hmm. I think what we're getting at here is a fundamental conceptual issue of what is depression all about. And I think if we reductionistically view it as a biochemical imbalance, then there's a tendency to just kind of sit and wait for the medication to work. If you look at this elegant twin study that Kendler's group did, you see that there are about 4 different factors that interact in a complex way to produce depression. Genetics, recent stressful events, neuroticism, and interpersonal factors. And you know, the single most powerful predictor of a depressive episode was recent stressful events. So when the medication is working, I'm also asking the patient about these recent stressful events. You look at the whole person.
And there's still the issues of the chicken and the egg in those situations. Does the depression cause the stressful life event? Does the stressful life event cause the depression? And who cares, because you really should address both issues anyway.
And the X factor are the stressful events that neither you nor the patient know are stressful. There are lots of those.
Someone, a therapist once said it was the absence of stress that caused depression.
Oh yeah? Who said that?
But you know, this is a real important issue that we're talking about, because often in this kind of stress diathesis model of illness, we think of stress in terms of major traumatic events. And one of the things that I think you find in depressed people is there's often a kind of unconscious meaning of something that seems relatively trivial.
Right.
I saw a college kid who was, the precipitant of his depression was that he got a 3.2 grade point average at a major prestigious university in his first semester. I thought that was really good. You know, 4 point was the highest.
Yeah.
He had a vision of himself as being a straight A student. He felt he let down his parents, he let down his own kind of ideal self. So this was very, very stressful to him. But to an outside observer, it would seem like a trivial matter.
Your self-esteem is really measured by the distance between the ideal and the real.
And it goes back to something that Bibbring wrote about some time ago, when there's a discrepancy between ideals and reality. Many of the people who are at high risk for suicide have a fixed view of what they should be, and they see themselves as falling far short of that. And nothing less than this idealized view of what they should be will satisfy them. So they're chronically feeling that it's hopeless to ever reach this ideal, and why not end it all, because they're never going to be what they're supposed to be.
I think triviality is really the clue that the average psychiatrist doesn't pay attention to, and that is that there are some things that are so distressing to another person that you would never believe in any way would cause such a major disruption in their life.
I have a great case, actually. It's not my own case, but it was one of my colleagues. It was a consultation. Yes. Yeah, I'm not talking about myself now. Yeah, my cousin called up the other day. This was a 70-some-odd-year-old woman who was referred to psychiatry by primary care with the chief complaint that she couldn't wash the windows. And this was Wisconsin farm, and they still had storm windows, so you'd wash the storm windows, put the screens up, and she did this religiously every year. And the primary care doctor said, well, it sounds like a sign of depression. Are you depressed? No. You lost interest in usual activities? No. Well, I still don't feel comfortable. I'll call in the psychiatrist, who went through the entire set of criteria for depression. And there was really nothing there, at least on the surface. And then she asked the woman, have you ever felt this way before? And she said, yes, about 1.5 years ago, when my husband and I attempted suicide. He died, and I didn't. And that was the only lead into a much deeper pursuit of a diagnosis of depression. I mean, if you talk about masked depression, that was masked.
What did you do?
Huh?
What did they do?
They eventually treated her for depression. But it took a lot of persevering to get beneath the, whatever you want to say, the denial, the resistance.
Let's see if there's some things that are commonly missed so that psychiatrists fail to make the diagnosis of depression.
You know, I can think of 2 times that I missed it because you never forget them. One was a person whose most outstanding depressive feature was an overwhelming sense of guilt, and that should have been a tip-off. And the other one was really driven by anxiety in association with the depression. And as I think back to both of those features, they should have been stronger signals than I picked up.
I think picking up on Jeff's point, in Fawcett's study of the differentiation of short-term versus long-term risk factors, this issue of anxiety comes across like gangbusters. We really need to be tuned in to major kinds of anxiety disorder symptoms such as panic attacks, such as anxiety, and treat the anxiety as aggressively as we treat the depression.
Yeah, I really fully agree with that. Clinically, seriously depressed patients who become very anxious and almost apathetic-like really scare me.
One of my favorite cases is a woman who was hospitalized in a state psychiatric hospital for 2 years with a diagnosis of dementia. And I was asked to perform a neuropsychiatric consultation. This woman was mute, performed virtually no self-care, had to be dragged to the toilet by the nurse's aides, wouldn't clean herself, wouldn't feed herself, had to have her food cut and placed in her mouth. And the one thing I got her to say was that when I asked how she was she said that she had breast cancer, which was not the case. And learning more about her, we found she'd had a prior history of a depressive illness years past, and this woman received a course of ECT and was vastly improved within 2 weeks, was fully alert and ambulatory and able to care for herself.
So she was catatonic.
She was virtually catatonic. Yeah. But
as a symptom of depression, as a masking of the depression.
Yeah, it's a case of so-called pseudo-dementia, and it's another example of way we miss depression is when we mistake cognitive symptoms for depressive symptoms.
It also helps to ask relatives of mute patients for some history.
Another interesting case that I've been following for about 15 years, a woman from Baton Rouge, Louisiana, who had been hospitalized a number of times, and before I saw her, she'd been about 9 months in a long-term care facility and was labeled with the diagnosis of schizophrenia because occasionally she got a little paranoid, but she never got better on neuroleptics. And I evaluated her at the time up in Rochester, and my clinical impression was that this was more of an affective illness, and decided that I would treat her with an antidepressant, and she's doing real well. She does occasionally get paranoid, and she responds to an incredibly low dose of haloperidol, 0.5 milligram a day. But basically, it's an affective illness that responds very well to antidepressant therapy.
It's very often the case that patients who say, I am hallucinating, are automatically lumped into schizophrenia, and nobody ever looks at them again.
The cases that have been described were at the upper end of the spectrum of more severely ill. I think the more common one, and equally as difficult, if not more difficult, are patients that don't meet the criteria for depression. And they have mild symptoms. They're not sleeping as well as they might, and they've lost a zest for life, and they're fighting with their spouse or not getting along so well in work, but they're functioning. They're just sort of smoldering along. I think they represent a big dilemma as to what to do, and there's more information coming out on the value of medication for these patients.
I think that is a critical factor, and that is the millions of people in this country who are mildly and chronically depressed all their life, who could be helped, who are really not the worried well, so to speak. They are sick. They don't have a reasonably good interpersonal life. They are labeled by their family as kind of loners or distant or not very happy. Nothing stimulates them, maybe 1 or 2 activities, but they don't have a joie de vivre.
Well, I'm just going to follow up on Myrna's comment about anxiety. I was sitting here thinking about in treating depressed patients and the countless things that I screw up, what do I screw up the worst or the most consistently? And I think that's probably what it is, because the ones that come to me typically come referred by non-MD mental health professionals. And typically what they'll say is, gosh, Ed, and they are doing a pretty good job, but they're not getting better. See if you think medicine might help them. And I wind up missing it completely, even though, I know in my mind how to make the diagnosis of dysthymia, and I know in my mind that the antidepressants do help dysthymics, and somehow or other I screw it up. And I think these patients are often chronic. It often is very difficult to separate out from their personality style. They really don't want to talk about being depressed. They're much more focused on psychological issues than on biologic symptoms. I don't do a very good job with this at all. I think it's tough work.
Well, I wanted to challenge something Dr. Settle said, because I don't believe he's incompetent.
Jeff knows me, and he can vouch for this.
Aside from that,
I think that those patients that have these mild symptoms, but they don't meet any criteria, are a real dilemma. Except we do know that in the long run, they tend to have episodes of depression, real episodes.
The biggest problem, difficulty I have, and my colleagues do, again, falls with these group of patients who have, quote, personality disorders. I believe there's a whole group that really are dual diagnosis that we haven't looked at in a systematic way. And they've been tried on every drug regimen and really aggressive doses. And as I told them, it's clear to me there's developmental issues, there's personality problems, and I'll start talking a little bit about the psychology of what might be going on. They say, listen, doctor, this is biologic. They told me that my TRH study is abnormal, my DST is abnormal, my sleep study is abnormal. This is something in my brain, and they just want more medication. And I think sometimes we do our patients a disservice by jumping too quickly that this is biologic, rather than kind of taking more of the middle ground.
I think there are really three different issues of the interface between personality disorder and depression. One is, of course, that we know from abundant data now that the presence of an Axis II diagnosis complicates the treatment of major depression. These patients don't do as well. They don't respond as well to conventional treatment. The second issue is the one that my colleagues are alluding to, which is that there is a dysthymia or depressive personality that is very much like a character style of a chronic depression, and we know about 40 to 45% of those respond to antidepressants. The others need psychotherapy. Then there's a third group I think that's important too, and that is the so-called characterological depression that you see in borderline patients, where they say the word "I'm depressed," but in fact they don't have the symptoms of a major depression. What they have is emptiness, conscious rage, a kind of yearning to be taken care of by others, and they don't typically respond to tricyclics, and these patients are often dissatisfied with any kind of treatment that they give because you're not becoming this kind of nurturing parent that they long for.
You keep asking me how I feel. I'm angry, but I don't know how I feel. You're supposed to figure that out.
children who don't get sufficient nurturance have a lot of aggression hidden inside of them. But underneath that depression, there's always a great deal of anger.
I think the relationship between aggression and depression, I think, are very understudied and underappreciated. There were two large studies done about 10 years apart, both which showed that 10% of the patients committing aggressive acts were clinically depressed at the time of the aggressive act. And when you look in the forensic literature, that theme has permeated a lot of the forensic literature, that perpetrators of homicide were clinically depressed at the time of the event. And you just, for the first time, I saw a paper published where they listed the differential diagnosis of aggression and they listed depression. And it's interesting because I think the thrust is going to give that even more impetus to think about and look at is some of the findings with serotonin. And I think that's going to give us more of a push to look at the relationships between aggression and depression.
If you look at the cerebrospinal fluid metabolites of serotonin, you can correlate lowered serotonin with both suicidal and violent aggressive acts towards others, so that there's some preliminary data suggesting that violence either way, directed inward or outward, is related to serotonin.
I think if you look at depressive sexual behavior and depressive illness, you'll find two groups. The one group who sort of withdraws, has low libido, and another group who's hyperactive.
Yes, Rod.
But I have always been very impressed with aggression among adolescents belonging to minorities. Now, this is not directly related to depression, but let me tell you of some findings. Usually, the case is that the parents are undervalued or devalued. They belong to a culture that is not appreciated by the dominant culture. So the kids grow up with an awful opinion of their parents and with a search for another identity, which becomes the gang. And one way of asserting yourself in the gang is by being violent. Eventually you end up in the largest psychiatric facility in the country, which is the Los Angeles County Jail. And what do you find there? But you find is a large use of antidepressants. The same happens, say, in the California state prisons. You get astonished at the numbers of antidepressants that the prisoners are asking for. Now, I am not saying that I am describing a formal study. I am saying that a lot of adolescents who do not feel very well about themselves, who do not have a sense of identity, who do not belong to the general community, are violent, end up in prison and needing antidepressants.
I want to make one other comment about the relationship of aggression and violence to depression. We have been taught by Freud and many others since Freud that underneath the depression is the anger, rage, and violence. So that if the psychiatrist takes a history and the person says, I hit my wife, or I kicked the dog, or I'm rotten to my children, we assume, well, they're not depressed because they're acting out the depression. That is an absolute error. One of the things we need to do is to recognize that, sure, it spills out, and sometimes there are these moments of rage, after which there's an enormous amount of guilt, and after which there's more depression. So it's kind of a getting into a vicious cycle of explosions, guilt, depression, but the basic issue is the depression. And I think that's something we have to pay attention to. In our diagnostic capability, we have to keep in mind not to have formulas about how to work up a depressed patient.
I think that it's something to look at, perhaps also in relation to substance abuse and what role that might play in terms of underlying depression or potential rage.
In some cases, it blocks out the diagnosis of depression.
I smoke more dope on weekends. That's the reason why I don't go out with people.
People assume that everybody who's on alcohol and drugs are self-medicating for depression. I mean, there are all kinds of misbeliefs in psychiatry in terms of the diagnosis of major depression and the comorbidity with alcohol. Yes?
There's some individuals that think that you can't treat for depression until someone is using substances or alcohol is abstinent for a period of time to see if the symptoms remit with abstinence. There's another school of thought that the people will not be able to achieve abstinence if they have an underlying depression unless that depression is first treated. And the truth is there are probably some patients in both camps, and it's hard to distinguish who's who.
But the reality about depressed patients with habitual alcohol and substance abuse problems is that there will be remission of these depressive symptoms once they have abstained from the substances.
We have a big debt to the people who have told us about dual diagnosis and the importance in hospitals. So up to recently, at least in California, it was very difficult to treat an alcoholic in a general hospital. Now that we have dual diagnosis, we are able to bring them to our psychiatric units and treat them. And clearly the superimposition is there, and many patients cannot be treated for their depression if you don't deal with their alcoholism.
I've seen a number of patients who were chronic alcoholics who finally cleaned up their act and descended into the deepest, most treatment-resistant depression you'd ever want to see. So resistant that it became tempting after months and months of attempting to say, go back and drink, because your life seemed very much better than it is now.
I know a lot of the people around the table are not following the idea that you send them back, that you might.
Well, no, I've never done that, and they've never been willing to do it either. So maybe there's a masochistic streak that allows them to suffer. But you think perhaps that the alcoholism was masking or attenuating what was a primary mood disorder.
The other part of it is after they get finished with the alcohol and they get depressed, in my experience, the depression is always, almost always, covering over a serious rage and a serious guilt. I mean, the enormity of the rage sometimes is so terrifying that they really need to be depressed. And I'm thinking of one man who had 10 years of alcoholism, finally went to AA and got rid of it, and began to recapture images of sexual abuse that finally led to his getting better through psychotherapy. But it was a tremendously difficult problem because he was so frightened of his anger at having been so terribly abused. Those are the kinds of cases that are kind of multi-layered in a sense. You take off one layer, which is the alcoholism, you get down to the depression, and you begin to deal with the depression, and you find out there's something else under there.
I don't know why my doctor wants me to see a psychiatrist, because my problem, it is not in my head, it's in my back.
I have spent all my adult life with the concept of depression, so I have become used to the idea that other people understand it equally well. When I went to California and started working with Hispanics, I realized that this concept is alien to them. The patients I was seeing did not believe in the meaning I gave to the word depression and did not care about it. When they had symptoms, they had somatic symptoms. And the psychological symptoms of depression were denied or attributed to the somatic symptoms. Well, if you have a chronic abdominal pain, shouldn't you be depressed? So I came to the understanding that one of the problems we have is that our concept is not selling well with some populations, one of them the Hispanics.
Well, I think it's similar in the Black or African American population, that there tends to be a lot more emphasis on somatic symptoms and a lot more of a stigma to go to psychiatrists unless you're quote-unquote crazy. And at least in the Black community, the church or pastoral counseling, I believe those are the folks that are seeing the majority of the patients who have either dysthymia or depression, because it's much more acceptable to go to the minister or priest or whatever with your problems rather than a psychiatrist.
How often is laziness or shiftlessness?
That's, I think, part of it. I think part of the sense that, you know, again, pick yourself up by your bootstraps and just get the work done. What do you mean you're depressed? Then, you know, that's meaningless. Just snap out of it. I think that's not only in the Black community, but I think we see that across the board.
Asians are very different. If you just look at the epidemiology of depression, Koreans are very, very different than the Chinese. We don't know much about the Japanese in those studies. They haven't been done. So I think we have to talk about where do they come from and what's their background.
I think it's important, regardless of the culture that you're speaking about, to look at the individual patient as an individual, keeping in mind the potential cultural effects. But that, you know, as you point out, Myrna, that the Asian population is quite different based on where they're from, as are Hispanic populations, depending on if they're from Mexico or Spain or South America, and within the Black culture as well, in terms of being from the South or the North or the West. And it's just important to just be sensitive to the potential impact of cultural issues, but not to impose your own idea of what should be the case.
Maybe now we should talk about regional differences. I used to live in New Orleans. There people would tell you. The women would take off their white gloves and their straw hats and would sit down and tell you all of their sexual difficulties with no problem. And the men would as well. In Cleveland they don't. Cleveland I have to ask. So I think there are major regional differences.
The Southern Belles in North Carolina don't talk about it.
But they may in their doctor's office. They may in their doctor's office. There may be a cultural thing. It's okay with the doctor to talk.
Dr. Bruce, telephone, please. Dr. Bruce, telephone, please.
Of course I cry. I cry all the time when I'm alone. You would too, if you had cancer.
I believe the pain of depression is real. I believe the depressed patient has real pains. All those pains depressed patients complain about, joint pains, extremity pains, diffuse pains, chest pains, abdominal pains. How can we say that they are not real? So depression is a somatic illness. Actually, it may be considered as an organic illness involving the brain. Then the other side, what about the other disorders. A lot of studies on heart disease, myocardial infarction, stroke, cancer showed that around 40% of the patients always come on the studies suffering depression. So clearly, organic serious illnesses have a serious depressive component. And also, the combination usually is missed, and of course people tend to say, if he is dying from cancer, why shouldn't he be depressed? Not knowing that the majority of the people dying from cancer do not have a clinical depression.
Lay people and patients themselves often think, I just had a stroke, obviously I'm going to be demoralized and depressed. But the work of Robinson has shown that depression after stroke is more common after left hemispheric stroke, and especially after anterior left hemispheric stroke. So it's not simply a matter of disability, but it's a matter of particular neuroanatomical substrate. And the risk is so high. I'm aware of 2 individuals with left anterior hemispheric strokes who committed suicide. One jumped out of the window of a neurology unit, and another shot himself with a gun as an outpatient.
I agree. We don't treat these, the depression often, which is a sequelae of these medical illnesses, as aggressively. I also think of Parkinson's disease and also Alzheimer's disease. And often in the early stages, these patients do develop a significant depressions, and we attribute to, well, they have Parkinson's or they have Alzheimer's. We could, I think, enhance the quality of life if we would treat these diseases more aggressively.
There's also the question of not recognizing, that is, the nurses, the doctors, other people, and psychiatrists trivializing, in a sense, the depression that may or may not be there, but the depression that is there when a person has a serious illness. I was called in a consultation before MRIs and CTs in which the woman had a cancer and she was not speaking, and she had a severe, terrible headache, and they wanted to know if she had metastasis to the brain. I went in and I found her lying in this bed with her face to the wall and the bed against the wall. And I pushed the bed away and I sat down, and we sat in silence for about 5 minutes, and then I took her hand another 5 minutes, and then I said to her in a very quiet voice, how do you feel about dying? And she began to cry. And she began to talk about how angry she was at having to die and having this cancer. And I said, look, I'll come back and talk with you tomorrow, and I'm glad we were able to talk and so on. I came back, and the nurses were infuriated because this nice, quiet patient in the corner was now carrying on in every way. So I said to them, how's her headache? And they said, oh, her headache's gone. The reality is that that kind of willingness to accept the withdrawn solitude of the depressed patient with the cancer or with the cardiac illness is part of the ethos of American medicine, and we contribute to that. And part of what I've tried to do in our hospital is get every cancer patient to have at least one consult with a mental health professional. Give them an opportunity. If they want it, if they take it, fine.
Well, I have almost the exact opposite case of yours. I have a case of a woman whose daughter died, and she passed into a deeply melancholic state, or was thought to be, where she was bedbound and lost a great deal of weight, and was finally brought into the emergency room cachectic, was admitted to psychiatry with a diagnosis of depression, and was dead of multiple cerebral metastases within 2 weeks. So very, very tricky differential diagnosis between depression and brain disorders.
Yes, Ed.
I think basically just a good history is really the key. I don't think any of these diagnoses were particularly brilliant. I think it was just a matter of asking appropriate questions and taking a good history, and also a willingness to get off of your butt and go do a neurologic exam. I would say the majority of these cases that I've picked up is when I've walked over and picked up my reflex hammer and found asymmetric reflexes or upgoing toes. And in fact, one of I think the best clinical laws of psychiatry is thou shalt never miss the upgoing toe.
Let's move on to some discussion about treatment now. First, we'll talk about medication and then some of the psychotherapies and other possible treatments. But I'd like to spend a significant amount of time talking about medication issues because I think the average psychiatrist, depending upon which decade he was trained in, may know anything from 0 to 100% about pharmaceuticals.
There are several considerations. One of them, the clinical picture.
Yeah.
The other one, the patient's history, prior depression's response to treatment, the family history, the circumstances of the patient, and of course other factors that may have to do with these precise patients. So the indications can never be fully precise, but there are factors that would indicate more of a need for medication.
And the thing that I look for, if this individual has a decrement in terms of functioning, they're not quite able to do what they were doing before, they're not working as well. Any indication to me that their functioning has been impaired, no matter how little.
Oh, I go to the office, and I have these files in front of me, and I just sit there and look at them, hours and hours at a time.
That's when I go ahead and use an antidepressant.
And I would be curious to see what falls out in terms of the data on treating dysthymia with medication. Because in looking back on my residency, which wasn't that long ago, I mean, I was told as a second-year resident, oh, this person doesn't need medication. What are you, crazy? You know, and in retrospect, treating this person for 2.5 years and seeing him get a little bit better with psychotherapy, but not tremendously better, and then hearing from the person who continued to follow him and did start medication after I left that he got better, I felt a little stupid.
I've been doing some work in primary care and just assessing some of the people that come through, and you see the whole range of these, particularly these mild depressions, and the question is, what do you do with them? Should you treat them? And I think there's two things to consider. One is that a sizable number of these mild depressions do at some point become major depressions, so if you treated them early, could you prevent that?
One of the issues I've had difficulty with is where people who are kind of on the borderline between what I would call a characterologic problem and a dysthymic disorder. And I've seen a lot of people like that whom I've not known, and they haven't really met formal criteria, and I've tried them on antidepressants, and some of them have done remarkably well. I remember one person I'm seeing now who is kind of a counterculture individual who was constantly on marijuana, living on beaches, and really described no symptoms of depression. We put him on antidepressants, so he went back and finished college and got a job.
I think that's easier to do today in terms of the available compounds that we have because of their low toxicity. So if we put a patient on an antidepressant, we don't have to worry about some terrible side effect.
And I think 10 years ago, I probably wouldn't have. I put all of my dysthymic patients in psychotherapy. And I think over the years, I've gradually started more and more of those patients on antidepressants, and more have been surprised. And I've actually gotten patients who don't actually meet criteria for dysthymia, who have some dysphoria and have had good responses.
Serious depressions, of course you're going to treat. The decision is pretty easy. The more subtle cases, I see the same thing you do. Some of these people just light up, and to me, if in doubt, treat. If in doubt, yes, we're talking about specifically with medication. If in doubt, use the medication. You may very well not use it in isolation. In fact, probably won't. But if in doubt, use it.
Do you adapt your pharmacological treatments to the elderly?
We look towards those drugs that have less cardiovascular toxicity, and those tend to be the newer generation compounds. But one, in general, should begin a dosage of any of these medications at roughly half of what we would for a younger, healthy adult. And this is because, in general, the elderly tend to metabolize these drugs more slowly than younger folks. But that's just in general, and you have many elderly who have no difficulty at all metabolizing these drugs. But just to be on the cautious side, one starts low and goes slow with the elderly in terms of dosage.
I would agree with Elliot that starting low and going slow makes a lot of sense, but it may be a mistake to stop low. I think you were saying that. I've got one patient who I think is 82 now, who didn't improve until she was on 450 milligrams of bupropion with lithium augmentation. And not only did she get undepressed, but she's been maintained undepressed for several years, and she tolerates that amount of drug very well.
I'm curious what other people's experiences are. One of the dilemmas I have with older patients, and that's primarily I do geriatric psychiatry, is that many of my older patients, there is a very strong element of anxiety. And I end up treating these patients both with an antidepressant and an anti-anxiety agent, and have a great deal of time getting them off the anti-anxiety agent, not because they become addicted, but because the antidepressant treats the depressive symptoms, but doesn't seem to treat the anxiety. And I'm wondering if that's other people's experience.
The symptom manifestation is anxiety, and then you can find the depression.
That's been my experience too. It's often interesting to me how low a dose of an anxiolytic you can use and still get very effective results.
But then I find you just can't, they need it, you can't seem to stop it.
So by and large, the indication for providing medication to the patient, we all agree, is that there is some dysfunction, there is some impairment, and there's certainly some degree of depressive symptomatology. And in that sense, we all agree that we would begin the antidepressant. But I think we need to talk about how you choose. What criteria do you use to choose one antidepressant over another? Yes?
I think it depends on the patient. In a geriatric group, I would clearly go with one of the newer antidepressants because I'd be worried about orthostatic hypotension, anticholinergic side effects. So that would put you towards sertraline, fluoxetine, paroxetine, bupropion. I think that would be I think most people would agree with that in terms of a geriatric group. Actually, if I look at my own practice, in most patients, I choose those 4 drugs and possibly trazodone for a more anxious, depressed patient. And I've looked at my prescribing practices actually before I came to this meeting, and I haven't written a prescription for imipramine, amitriptyline, doxepin for years unless the patient comes in on those. Dizipramine is probably the only one of the older ones, or TCAs, that I even prescribe anymore. And that's probably because it's a little cheaper than the newer drugs.
Look at the side effects and try to match those to the clinical picture. But there can be very strange permutations. I recently was, being on the Pharmaceutical and Therapeutics Committee, was thinking about taking nortriptyline off the formulary, but some of the geriatric people really objected because they say they do have patients who lose weight on Prozac, SSRIs, and they need to have something that doesn't produce orthostatic hypertension but does not reduce appetite. So there turns out to be a very unique, small but unique place for that, for nortriptyline.
Actually, dizipramine may be as good as nortriptyline for both, I think.
Yeah, my feeling is that the evidence shows that all antidepressants are equally effective. So the choice has to do with the personal and family history of the patient, with the side effects of different medications, with the medical condition of the patient, his age, and any other medical considerations. Not necessarily the effectiveness of the medication, because again, they may be equally effective according to what we know now.
Something else to be curious about, or that clinicians should begin thinking more about, are the potential differences between men and women in their response to medication. Is there a change in response to medication in women across the menstrual cycle? And also, what ethnic or cultural differences exist? There have been a few studies, but not a lot, and that's, I think, we'll need to look more at that in the future.
I'd like to ask a consultation. There are many people who maintain that for the most severe forms of depression treated on an inpatient service, that the newer SSRIs have not shown the same proven efficacy as have the tricyclics. And I wanted to know what you guys' take is on that.
The senator from Wisconsin.
I'm not sure the SSRIs have not demonstrated efficacy as opposed to not having been studied in the inpatient setting.
Not proven their efficacy is what I mean. Yeah.
There have been some inpatient studies with bupropion that have shown it to be effective in inpatient depression. One of the problems with comparative studies with the tricyclics in inpatients were done years ago, and the populations now that end up in the hospital for the treatment of depression may be quite different from what was treated 10, 15, 20 years ago in terms of, I think, being more severe, perhaps more treatment resistant, and with less availability of time in hospital to be treated. So doing the proper studies today are virtually impossible.
Ed.
I really want to endorse that comment. Inpatient
Depressives today are dramatically different than they were 20 years ago. I'm unaware of any good data that document that the newer drugs, the SSRIs or bupropion, do not work in inpatients. I think, in fact, there's a great deal of anecdotal evidence, which I think is important, that they do, in fact, work in inpatients.
Glenn, there's another large group we haven't talked about too much. Those patients with borderline personality disorder have a rate of Axis 1 major depression as high as 70% in some studies. Within that group, we have double-blind controlled studies by Cowdery and Gardner suggesting that MAOIs might be particularly effective, certainly much more effective than tricyclic antidepressants in the borderline patient with major depression, where the results are equivocal.
One group of patients that I would use MAOI as first drug of choice would be when you see major depression, a Venn diagram that would interconnect major depression and anxiety disorder and what appears to be a somatoform disorder. When the SSRIs came out, people were hoping that they would essentially replace MAOIs with atypical depression. I've not found that to be the case with these patients.
We're eagerly awaiting the new generation of monoamine oxidase inhibitors, the so-called reversible monoamine oxidase inhibitors, that are reported to have less side effects, particularly the interaction with tyramine. But in the meantime, I use monoamine oxidase inhibitors a lot, but it's never the first-line drug unless it's a patient who's in the past has been on it and responded and has been off the drug.
When do you use it a lot? For what reasons?
I've got a failure on just about everything else beforehand.
One of my most memorable cases was a woman who was wealthy enough to spend about $50,000 in personal funds going to different medical centers with a conviction that she had either multiple sclerosis or muscular dystrophy or some degenerative disease. And she was really asymptomatic within 6 weeks of starting a monoamine oxidase inhibitor.
Another point we didn't mention that ties in with when to use MAOIs is the subtyping of depression. The point was made that depression tends to respond to everything about the same, but the everything is defined as major depression outpatient type in 18 to 60 or 65-year-olds. And whether or not one uses an MAOI first, there is evidence that bipolar depression responds better to MAOIs than tricyclics, and that atypical depression responds better to MAOIs than tricyclics. It's a little less clear how the SSRIs and bupropion compare in those categories, and those are areas where it would be very nice if the newer non-tricyclics were as effective as the MAOIs, because they're clearly easier drugs to use.
They're very, very useful compounds. I guess the point that I consider fairly important about them, though, is I'm not sure physicians, including psychiatrists, should use MAOIs unless they're going to be using them fairly consistently. If you're going to use an MAOI once every 2 years, I'm not really sure you ought to be using them because they are toxic compounds if they're misused. The other point, though, I do use a fair amount of MAO inhibitors, is I think they're not only good for atypical or unusual or sort of on the margin cases of depression, but they're also quite good for standard major depressions that fail to respond to standard antidepressants. It's not real unusual for those patients to be put on an MAO inhibitor, even though they don't have atypicality or unusual symptoms, and do very well on them, where others had failed.
The other side is, in terms of thinking about MAOIs, I think a lot of clinicians are afraid to use them because of not knowing if the outpatient's going to be able to follow the diet, follow the restriction. I think the most important thing is to feel you have a connection with your patient, that they will call you before taking an over-the-counter medication, or will call you and ask you.
I just wanted to raise an interesting issue that I've seen. I think now that there's been a shift to the newer drugs, we used to have a problem with the tricyclics, and it's well known that psychiatrists tend to use too little and underdose. One of the problems I've seen occur with a number of psychiatrists is the opposite, especially with the SSRIs, is they overdose the patients. The minimal dose is usually the most effective dose. And I've seen a number of...
Why do you think that is?
I think, bluntly, they haven't read the literature. And so they assume, well, I'm supposed to titrate it just like I do the tricyclics. And so they raise the dose very quickly, and then you get this, either the patient can't tolerate the drug, or well, usually you get the complaint, well, they can't tolerate the drug. But the fact is, They really just didn't put them on a minimal effective dose and leave it there for a couple of weeks to see how they do.
Jeff?
Yeah, I think an additional reason for that is the need that people have to do something in the process of treating depression. It's very hard to sit back and say, stay on X milligrams of drug for 4, 6, 8 weeks, because something will eventually happen. And I think it's a problem in primary care too, that the newer drugs tend to get overdosed because people don't realize that they have a relatively flat dose response.
I've been on this drug for 2 weeks and I don't feel any better. Can't we try something else?
But I think it's also important to recognize the patient's distress and concern about, not seeing any change. And I think certainly what I try and do is inform them ahead of time that this isn't like a heart pill that you take and your heart pain goes away, that it takes a longer time, and usually that's helpful.
How do you monitor, and how do you say to a person, this drug will work, just hang in there, or you haven't given it a chance at the proper dose. I'm in charge of this case and I'm trying to help you, and this is what I think you need to do. We know that the patient gets impatient. We also know that physicians in general don't have a sense that they can do nothing and they've done something.
Sometimes doing nothing is great. I really think one has to do something every time, because in that way you give the patient hope, and that carries the individual from session to session.
I didn't mean you didn't talk or you didn't give hope. I don't mean that you should do irrelevant and superfluous things, or in terms of what you and Elliot have been saying, not raise the dose when it's not supposed to be raised. I had the same experience with one of the SSRIs. I put the patient on 20 milligrams, didn't work, put him on 40 milligrams, put him on 60 milligrams, and then Bill said to me, what the hell are you doing? And I took him down back to 20 milligrams and kept him there for a while, and he did okay. So it was my own anxiety about it, and not understanding and not reading about the drug, and a variety of things I should have been doing.
We really have to be systematic. Use one drug for an adequate dose for an adequate period of time, and too often we because of the pressures from the family and everyone else, we sort of start using shortcuts, and we don't follow the systematic adequate dose, adequate duration. If we're on a tricyclic, get a blood level if they're not responding.
When do you make a decision to switch from drug A to drug B? You indicated before that once you feel confident that this drug is not working, you've given it an adequate trial, you've had a good dosage, the blood levels and so on.
Well, I think we should get back to that point, because theoretically it's nice to treat people for 6 to 8 weeks with a given antidepressant, but practically I find it very difficult to sit when nothing is happening for anything more than 3 weeks without making some kind of additional intervention. And often the intervention is to add something. I find it difficult treating someone medically to stop a drug and wait and then replace it with something else, as opposed to adding something. I realize we get into polypharmacy, but I think that monotherapy treatment falls apart in practice very quickly in someone who hasn't responded to the original treatment.
Yes.
Which is another reason really to consider augmentation approaches, since not only do they probably help in and of themselves, but they buy you some time to convince that patient to stay on the original medicine for another 2 or 3 weeks. So you can get a 7-week trial rather than a 4 or 5 week trial.
One of the issues that's come up is therapeutic drug level monitoring. And although the APA task force a couple years ago came out fairly strongly in favor of drug level monitoring, during the task of helping to edit these guidelines, I became aware from many experts around the country that drug level monitoring is not being done by most expert psychopharmacologists. I tend to do it, but I'm not sure that I'm doing the right thing. I'm not sure it's helpful.
There are only a few drugs, as you well know, in
Yes.
guidelines, tricyclic antidepressants, for which we have established the therapeutic range. All others are based on minimal data and projected based upon the tricyclics. And for the newer compounds, it seems to be there's no relationship between blood level and response. So if you want to be very rigorous in terms of practice, if you're going to get a blood level on a drug, that patient ought to be on a drug that we have well-defined therapeutic ranges.
Yeah, but even a drug like nortriptyline, the therapeutic window is not quite firmly set. Maybe 150, maybe 170 nanograms.
But I think you can't always treat the patient on the basis of the laboratory test. I picked up a patient many years ago from a resident. This patient was on 125 milligrams of imipramine and had a blood level somewhere in the range of 450 nanograms per ml. And this is well beyond what we call therapeutic, which is probably of the order of 150, 200 nanograms per ml. Patient had no side effects. The resident was very concerned about that blood level and dropped the patient down to 100 milligrams per day, and the patient got depressed. And so I just bumped the patient back up to the dosage where the patient wasn't depressed and ignored the blood level. So you can't rely totally on the blood levels to make your clinical decision. Additionally, I had a patient, a young man, who was on a tricyclic. I think, again, it was imipramine. He was a heavy smoker, and he was on close to about 500 milligrams a day of that drug, but then the blood level was useful to me because he was barely in the therapeutic range with that dosage.
One of the things we haven't done with regard to pharmacology is talked about the time needed to switch from one drug to another, that someone would come off the drug and be on nothing.
The important thing to emphasize here is the serotonin, or the selective serotonin reuptake inhibitors, and switching from one of those to a monoamine oxidase inhibitor, because this can result in a lethal outcome, which is called a serotonergic syndrome, that is most of the time fatal. So one has to be very careful about that, and if one is going to switch from an SSRI to monoamine oxidase inhibitor, one has to give adequate washout. And the rule of thumb is that it takes about 4 to 5 times that elimination half-life to wash out greater than 90% of the drug. And so one has to have some information about the elimination half-life, and it varies. Generally, the drug paroxetine and sertraline have an elimination half-life of about 24 hours, so it takes 4 to 5 days to wash that out. But I would give an extra measure and wait perhaps another 4 days or so. On the other hand, with fluoxetine, one has a much longer half-life, which is the order of 3 or 4 days to wash out. Half-life. So to wash out takes of the order of 12 to 15 days. But with fluoxetine, there's another problem, which is the active metabolite, norfluoxetine, which has a reported half-life of about 6 days, but one can glean from the literature and anecdotal reports that it could be as much as 16 days or 18 days of that order. So it's recommended for that drug that 5 weeks is a washout period. Now clearly that's a problem if you want to switch from that drug to a monoamine oxidase inhibitor, because you've got a patient who's depressed and you're going to have to wait a long time before you start that. I think you might temporize and you might think about switching not from an SSRI to a monoamine oxidase inhibitor, but to another class of drug. For example, as I do often, from an SSRI to bupropion. And then if bupropion doesn't work, it's an easy task of switching from that drug to monoamine oxidase inhibitors.
Any other safe switches?
Well, yeah, switching from an SSRI to a tricyclic. Some people are viewing that as a useful augmentation strategy, that the addition of a tricyclic to an SSRI may be beneficial, and sometimes when one is in the process of phasing one in and the other out, you get a response while someone's on both drugs. There are drug interactions, especially with fluoxetine, that have to be considered because it inhibits metabolism of tricyclics as well as other drugs. So you would probably want to start with a lower tricyclic dose in the presence of fluoxetine, and possibly the other SSRIs too, which I don't think are totally immune from this type of interaction. There's one other interaction with the MAOIs, and that I think was brought up briefly, selegiline or eldepril. Even though it's a selective type B MAOI, there have been some case reports of serotonin syndrome when that drug has been combined with an SSRI.
Right, because it's only selective in terms of concentration, and we don't know what each patient is in terms of concentration, but if you get to high enough concentration, you start to inhibit type A. one thing that is becoming commonplace these days is to use trazodone as a hypnotic, particularly in patients who are on monoamine oxidase inhibitors. And if you read some of the literature, you would say, well, that's contrary to what I was just saying, because trazodone is an SSRI. It does block the reuptake of serotonin, so it does potentiate serotonin. But the reality is that it's much more potent at blocking serotonin receptors than it is at inhibiting reuptake of serotonin. So the net effect is to decrease serotonergic function. And that would fit because one can, with impunity, as I have prescribed and it's been in the literature, using trazodone in combination with a monoamine oxidase inhibitor.
One of the things I discovered in my work on stigma is that psychiatrists and other mental health professionals have as much stigma against the mentally ill as anybody else. And one of the issues is the question of the psychiatrist's wish to get the patient off the drugs. What does that do with the issue of maintenance?
I think the evidence is very strong in terms of the disease being recurrent. And I tell my patients that this is quite clear, and this is just like having insulin-dependent diabetes. You keep on this medication forever because you've had a couple of illnesses before, depressions, you've gotten into trouble, and I know that we can help you prevent recurrences by maintaining the drug.
We jumped right into maintenance without saying very much about continuation. Continuation refers to the process of continuing an antidepressant after remission is achieved in order to preserve that remission. And studies indicate that antidepressants need to be continued for 5 or 6 months in order to preserve that remission after it's induced. Maintenance refers to further prolongation of treatment after that single episode is entirely treated in order to prevent recurrences. And those two issues are sometimes confused. Everyone is appropriate for continuation therapy, but who is appropriate for maintenance therapy? If someone's had 2 episodes, say 12 years apart, should they be on maintenance therapy?
If you take somebody who has 3 episodes a year for the last 5 years, I don't think there's any question about long-term treatment. If you take somebody who has episode 12 years apart, I mean, you're sort of whistling in the wind in terms of whether your treatment's going to do anything.
Sometimes the patient decides for us because it's about 6 months out, you start reducing the dose and the symptoms come back. So then you keep them on for another 6 months and you try to reduce the dose again and the symptoms come back. Sometimes the patient will themselves tell you that you can't, that you got to keep them on maintenance.
I'm curious how people deal with maintenance with the psychotic depressions, because I find the literature not helpful. And that if you treat the initial episode or the episode with an antidepressant and an antipsychotic, do you continue the maintenance treatment with both drugs? Do you drop off the antipsychotic as you move away from the episode? If it's a person who's had multiple episodes of psychotic depression and you conclude they really need a long-term treatment, do you use both drugs?
It seems to me that it's important to dichotomize whether the psychotic symptomatology is mood congruent or whether it's mood incongruent, because I think that does change follow-up. In my experience, you can often treat the mood congruent psychotic patient just with antidepressant or mood stabilizing medicines. But patients where it's mood incongruent, I think then the neuroleptic and real low doses sometimes does have to be continued. What's your experience with that, Bill?
I used to treat them in the acute episode either with the combination and then ECT, and then discharge them just on an antidepressant. I haven't been happy with that. It seems like they relapse very quickly. So I'm moving now to keeping them on both drugs for at least 6 months to a year.
I think people listening to this tape need to have a little more sophistication about depression complicated by other medical conditions. Most psychiatrists tend to use drugs with which they've become familiar, and so they don't understand some of the nuances that are important when someone has problems with other organs. I'd like to start with people who have cardiovascular difficulty. Elliot, you've talked and written about some of the newer compounds that are available, the such as the so-called selective serotonin inhibitors and the non-serotonergic drugs like bupropion, which all appear to have lower cardiovascular toxicity. I wonder if you'd comment about that.
There have been some anecdotal reports of bradycardia associated with fluoxetine, and probably might occur with some of these other SSRIs. But in general, they're much more benign drugs in terms of the cardiovascular system. And so if you are faced with a patient who has cardiovascular disease, and that would tend to be the older patient, then this is the group that you'd want to focus on.
We've known for some time that the tricyclics alter cardiac conduction. We've known that they cause orthostatic hypotension, especially in people with pre-existing cardiac disease. There's a new suggestion that the tricyclics may also actually be arrhythmogenic in patients with myocardial ischemia. An article came out recently by Sandy Glassman in JAMA suggesting that even though the tricyclics suppress ventricular arrhythmias at therapeutic concentrations, that when there's myocardial ischemia, they actually may cause ventricular tachycardias. So there are even new forms of worry about the tricyclics in terms of the myocardial
Speaking of the Glassman article, he published a paper several years ago in the Archive of General Psychiatry on the cardiovascular side effects of tricyclics. And in that paper he said that the single most significant cardiovascular side effect of tricyclics is postural hypotension. And that is very common with the tricyclics.
I agree with what Sandy Glassman said about orthostasis. Clinically, one would think that the more malignant sounding cardiac events, the conduction problems and the arrhythmia, would be the major players. But from a clinical standpoint, it's really orthostatic hypotension that gets you in trouble with patients because it's so common.
While on cardiovascular effects, I just want to say the other really important advantage of the newer compounds is they're not as lethal in taking an overdose.
I'd like to hear from Jeff, because he's written a rather definitive review on cardiovascular side effects.
If you look at the New York State Psychiatric Institute studies, which seem to be almost the only ones that have been done, when they looked at older patients with conduction defects treated with tricyclics, I think it was only 9 or 11% developed complications during the tricyclic treatment. If you look at the treatment of cardiac arrhythmias with antiarrhythmic drugs, at least that percent get worse rather than better. The main point is that why even take a 9 or 10% risk today when you don't have to?
I'd like to go the opposite and be basic. Orthostatic hypotension means that the psychiatrist will get a complaint of dizziness, falling, not able to get up. If the psychiatrist has somebody who comes in and he says, I've been lightheaded, he ought not to send that person for a neurological consult. He ought to know enough about side effects and the cardiovascular side effects. I don't want to imply a total lack of information, but I think we have to be as specific as we can about what we're saying. And you've all said that orthostatic hypotension is a critical factor in assessing the use of drugs, and it's an important thing for us to pay attention to.
There was a very interesting article by Ray and colleagues in the New England Journal a few years ago where they looked at older patients who were on tricyclics, and they found a linear correlation between the amount of hip fractures in these patients and whether they were on an antidepressant, and if so, what dose they were on.
Just make the point that lightheadedness is a pretty non-specific complaint, and you really like to tie it into positional lightheadedness, and then it would be nice to confirm that by taking postural blood pressures.
I think in our practice session, we really should have a blood pressure cuff and be routinely doing the blood pressures on our patients. In fact, one of my patients likes me to do it better than the internist because he doesn't make her stand up, and I do.
What you often hear is nothing. They don't tell you. And you have to ask, and if you don't ask, you don't know, and until it's too late.
But what they say is, help me, I've fallen, I can't get up.
No, but that's, Ed, I think that's critical.
And what you hear is doctor, your patient, my sister, has been admitted to the orthopedic service. You know, that's what you hear, because they don't bother.
Hopefully we can avoid that.
I did have an elderly patient who had a number of medical problems, including cardiac problems, who had not been tolerant to the traditional tricyclic antidepressants, had become orthostatic on TCAs, was refusing surgery because of the degree of her depression for her aneurysm, was cachectic, not eating, and so forth, was also refusing ECT, and ended up treating her with bupropion and had a remarkable outcome. It's important to really consider the newer antidepressants in elderly patients, in patients with complicated medical illnesses, particularly cardiac illnesses.
Griff.
I was just going to say there are different ways you can group the side effects, and one important group, I think, are the side effects that tend to cause people not to take the antidepressants.
I think it's also very important to inform patients that any symptom they get that's different from usual may be a side effect. It doesn't have to be in the package insert, it doesn't have to be in a textbook. It can be their own special, private, idiosyncratic side effect that really is caused by the drug.
I know the depression's getting better, but I'm, you know, just not functioning.
Taylor can point out the sexual dysfunction problems with clinical trials.
I think the main thing in terms of the newer antidepressants is the SSRIs have a lot of anorgasmia associated with them. I don't think we really know yet how frequently. If you look at fluoxetine, I think the original reports were like 8, 11%. Now you see reports of 65%. And so I don't think we know with sertraline or paroxetine yet. I think this is a major problem with SSRIs, and I don't think we ought to put a patient on those without warning them.
Inability to get an erection or delayed ejaculation?
It's delayed ejaculation, delayed orgasm. I currently have a female patient, a newlywed, who was put on fluoxetine, became anorgasmic, was changed to sertraline, was still anorgasmic, and I had to switch her to bupropion. I think from the current data, it looks as if bupropion and maybe trazodone are relatively devoid of sexual side effects. The problem with trazodone is priapism, about 1 in 10,000 I think is the estimate.
There is no way to adjust these drugs to get rid of the symptom, as I understand it.
There are a couple things you can do. Occasionally with the SSRIs, not fluoxetine, but with the shorter half-life ones, you can ask the patient to delay the dose to after intercourse. Occasionally I found that to be successful. The other thing is if you have to keep a patient on the drug they're on and you can't switch, one of the things you can do with SSRIs is use a low dose of yohimbine. In fact, I've just got a patient this last week on sertraline that I gave yohimbine to, and that worked.
I'm going to make a point about yohimbine that it can have side effects, including increased heart rate, increased blood pressure, and anxiety.
It's a potent antihistamine, so it causes sedation.
What dose did you use, Taylor?
It comes in only 5.4 milligrams. I start them off with, tell them to take a half of it. If that doesn't work, take a whole pill. And I've got other patients in sertraline who have delayed ejaculation. I tell them it can be solved, and they say it doesn't matter. It's a very individual thing. There's been one report, which I haven't gotten hold of yet, of clitoral priapism with trazodone. I know there are unpublished clinical trials of fluoxetine for treating premature ejaculation and paroxetine. And I've done an unpublished trial with anafranil treating
20
premature
years ago
ejaculation.
we used Nardil. It was one of the drugs that delayed ejaculation. It didn't eliminate orgasm.
It actually might be an indication for the use of a SSRI. It's somebody who's depressed and has premature ejaculation.
The men who say it doesn't matter obviously have a sense that their sexual function is not dependent on being orgastic immediately or at their will. And that's a psychotherapeutic question.
Well, there's another dimension to this, to be more specific about it, which is one of my patients on sertraline who had retarded ejaculation said that his girlfriend loved it. And he didn't want me to mess with it. So, you know, you have to individualize it.
Taylor, what about decreased libido? What's your feeling on that with SSRIs?
As far as I know, there's been one report of around 20%.
Male or female?
This was a male population, if I remember correctly. There's been very little controlled study in this area. We just don't know.
Now, some patients with depression will come in complaining of a loss of libido. Then what do you do?
I think you'd go to any antidepressant, but the things that might make sense would be bupropion or trazodone, because there's some anecdotal evidence that those two may have a libido-enhancing effect. Strictly anecdotal.
One level that we're not dealing with has to do with the attribution of problems in the relationship. And to many people, loss of libido means I'm no longer in love, you know. And there's a great deal of data on how severe the marital impact, couple impact of depression.
Yeah.
And so I always, in giving an SSRI, discuss it with people, mention that there may be some way to reverse it if it's a problem, simply to avoid this being attributed to a problem with the relationship.
I'm interested in your comments on this, that the sexual difficulties on MAOIs seem to me to be a little more clearly dose-related than with SSRIs.
Yeah, the literature suggests that. Sometimes you can actually decrease the dose and still get a therapeutic effect.
Sometimes you can find sort of a middle ground if you're lucky. Yeah.
The other piece, though, that I wanted to say was that I think perhaps it's becoming more recognized with fluoxetine in that because clinicians are becoming more aware that it's a problem and asking about it. And I find with the patients that I have seen that if I don't bring it up, they're not going to bring it up either because of embarrassment.
My experience as a sex therapist is that you cannot allude to it, hint about it, or go around any corners about it. You have to ask specifically.
And I think frequently people are hesitant to ask elderly patients about what's going on with them sexually, but it's an important part of their lives and important to bring it up again in a very matter-of-fact way.
Are you having any trouble getting an erection? Are you having any trouble achieving ejaculation? Are you having a delay in ejaculation? Are you losing interest in sex? Have you avoided sex? Are you unable to have an orgasm? Those are specific.
One thing I forgot to mention earlier is the MLIs have a high incidence of anorgasmia. And there have been controlled studies in that area.
Ed?
The only decisions to make are to realize that you're in deep trouble when this happens. The actual facts are that with tricyclics, weight gain is disturbingly common, far more common than almost any textbook would indicate. I could fill the next 2 hours with anecdotes of my patients on tricyclics with weight gain, but the one that comes immediately to my mind was a 45 or 50-ish year old lady with a major depression who I put on, I believe, dizipramine. This has probably been 7 or 8 years ago. Who had always been rather tall and slim and elegant and never had a weight trouble and was really sort of proud of that. And on the dizipramine, she just progressively gained 10, 15, 20, 25, 30, finally 40 pounds. Some patients with this have sweet craving, others don't. She did, and told me the story that one night, just before bedtime, in fact she was dressing for bed, just on an uncontrollable impulse, she went downstairs to her kitchen, baked a German chocolate cake, including icing, sat down, and over the next 2 hours, ate the entire cake.
You've given me a whole new life, Doctor. I'm going to be the fat lady in the circus.
And she told me the story, and she was somewhere between laughing at herself and crying. She really didn't know what to do. It was just an unmanageable side effect. And in my experience, there's just nothing you can do except get them off of a tricyclic and put them on one of the newer agents.
I had a patient who didn't bake the cake but actually ate the cake mix because that's all they could find in the house. There's just an overwhelming urge.
So it isn't just a matter of sweet craving, it's a metabolic effect as well. And gosh, talk about something that'll lead to non-compliance. Patients just won't put up with this. I've never personally seen any intervention help this, and if anyone has any ideas, I'd sure like to hear what they are. The only thing I've ever found to work is to switch to a newer drug.
The new SSRIs in particular are more likely to cause GI problems, starting with anorexia, nausea, and vomiting. And it's a continuum. So those are the drugs that tend to cause loss of weight rather than gain of weight. But I had a patient on fluoxetine who literally lost about 30, 40 pounds, and he didn't want to lose that. Of course, not all patients respond that way. I had a physician recently that I put on sertraline who got so nauseated from it, just had to stop it within about 10 days of starting it.
Yes, Bill.
I'm just curious, when you get nausea or sometimes vomiting from the SSRIs, I know some of the guys on our staff will add a little compazine for a couple of days, and that seems to tide them over. Do you have any strategy like that you use?
I haven't had enough experience, but I certainly wouldn't add compazine. I think I would be inclined to try to reduce the dose and see if that worked, and if that didn't work, I would go to another compound rather than add something like that.
The tendency to push the dose too fast, and what you do is you push the dose up into the nausea vomiting range, and you have a non-compliant patient very quickly. I would agree with Elliot that backing off the dose and proceeding more gradually is probably the easiest way to deal with it, rather than adding something like compazine or omeprazole.
Given these drugs, I became aware of how many people do not have breakfast. So they would take the medication early in the morning, get nauseous, and then would have breakfast 3 or 4 hours later. So I got in the habit of asking whether they eat around the time when they take the medications, and often I suggest that they take it after breakfast. Then I have to tell them to have breakfast.
Breakfast? Who has the time to eat breakfast? I'm still not sleeping better. In fact, I feel more anxious than before.
I don't think psychiatrists are that attentive to the early warning sign of sleep deprivation or lack of sleep or inability to fall asleep or inability to stay asleep.
It's probably not good for bipolar patients to work rotating shifts, to stay up all night studying for exams. I think there really has to be a lot of sleep hygiene education involved, and also using the disruption of sleep as an early warning sign of impending mania. This may be one of the places where short-term treatment with a high-dose benzodiazepine may be useful in aborting a manic episode.
See, I think that issue, the nature and quality of the sleep of the patient, has been clearly not attended to, not just for incipient mania, but also that the depressed patient suffers enormously from problems with sleep. And it's my understanding and my experience, it's the first symptom to come and the last symptom to go. Sleep is really one of the things that troubles them most, and they mention less frequently because they just think it's a part of their life pattern.
A lot of patients will not tell you that because the press has done a good job in stigmatizing sedative hypnotics. And I've had a lot of patients say, I don't want to sleep medicine because I'll become addicted. And so they do downplay the sleep problems.
It's interesting that the newer antidepressants, by and large, aren't terribly good sleep regulators early on, the first few weeks of treatment. And I think it's often helpful to give people some form of a hypnotic for the first couple of weeks if they're on a newer antidepressant. I think if you can get them to sleep better, they do better.
Absolutely.
I've been on this drug for weeks. I don't feel any better. Can we try something else?
I'd like to just ask one other question. How you assess the non-responder? What you do? Yes, Seth.
Treating non-responders is the perfect example that if you took 20,000 psychiatrists and stretched them end to end, they still wouldn't reach a conclusion.
You think it's a dumb question?
No, I think it's an outstanding question, but it's really hard to get any agreement on.
Well, let's get some disagreement.
Basic principle.
Yeah, go ahead, Jeff.
I would think, somebody who hasn't responded, you want to be sure they're compliant. You want to be sure you or whoever's treated them has treated them with an appropriate amount. I can't say a high enough dose now, but an appropriate amount. There are these disturbing data with fluoxetine that some patients respond by doubling the dose and other people respond by halving the dose. But be that as it may, you want an adequate trial of drug. You want to be sure you really are treating depression and you've recognized all the comorbid or complicating features. And I think many people at that point in time would augment the drug that hasn't worked. And I agree with you, once you get beyond an augmentation strategy or two, this becomes the art of psychiatry rather than the science.
In each case, we're exploring the possibilities of pharmacotherapeutic issues, psychotherapeutic issues, and the other thing we should keep in mind in this discussion is somewhere between 10 and 25% of patients just won't respond to medication, period.
A crucial factor is timing. You talked before about the psychiatrist who would be tempted to continue increasing the fluoxetine during the first few weeks of treatment because the patient's so desperate. There's another tendency that people might have to continue the same dose of a medication without adjusting it for months at a time, waiting for a treatment response. So the issue really becomes when to do nothing and when to stop doing nothing and start changing something. And I think most people would agree that 6 to 8 weeks is time to reassess what you're doing if there hasn't been a good response.
There's also the question of them being so intolerant that they cannot take it even for minor cholinergic symptoms that are troublesome to them, dry mouth, for instance, and you say to them, look, you have to take the drug, please take some water or carry a little bottle around with you or just dampen your mouth or try to give them some support and advice, and they just can't tolerate it. And then the question is your next steps. What do you do?
There are patients who refuse antidepressants. There are patients for whom there's no alternative but to admit them to the hospital involuntarily and seek a court order for meds because they don't understand the need for the medication.
Or the need for other therapies like ECT.
Shock therapy? Isn't that what they did to Jack Nicholson in that movie?
Many people still have myths about ECT that go back to the late 40s and early 50s. I tell families that comparing the myths they have about ECT would be like comparing surgery today the way it was during the Civil War.
I can't say anything that Bill isn't going to say better. ECT is underutilized and a tremendous treatment and may arguably really be the true gold standard for depression as opposed to tricyclics. Once you see this work a time or two, you're sold very quickly. This is a dramatic treatment.
Ed really said it. I think we withhold it too long. I think we still, I think that the indications for ECT are patients who are severely suicidal, have had severe weight loss with malnourishment. And this is a personal preference, but I think for psychotic depression, ECT for me is the first treatment of choice because, especially with older patients, you now have to put them on 2 drugs, worry about side effects, where it's very quick acting and very effective.
And I would not wait 3 months out of work. I see as an effective treatment to be used in severe depression.
I know a lot of programs or hospitals develop these sort of artificial protocols based on no data, and they'll say, well, the patient has to fail X number of trials of antidepressants before we'll give them ECT. I think that's withholding an effective treatment. Why subject them to another possibly 1 to 3 months of drug trials when you can treat them right at that point in time and probably get them well? So I believe in the aggressive use of ECT, and we've now extended to maintenance ECT for either people that would not tolerate drugs or were true drug non-responders. What we find is a lot of the, quote, non-responders were really never given adequate trials. In one vignette that I'll just tell you, which is kind of our amazing story, we've written this woman up twice. This was a woman, an immigrant to this country, that was in the state hospital for 16 years. She had actually what was a rapid cycling bipolar illness, and we now know from our following this woman that every 12 to 14 weeks, as sure as the sun will rise, she will cycle. So she never got discharged because just when she'd be about at the point of discharge, she would have another episode. Well, lithium came out. They put her on lithium, and lithium just didn't do it for her. Finally, they put her on Tegretol, and she developed agranulocytosis. So they said, well, we're going to still move her to the community and try her. In 2 years, she was hospitalized 5 or 6 times with manic depressive episodes. But for the first time, her treating psychiatrist said, well, let's try ECT. So the ECT would treat the acute episodes, but then she'd be discharged to the community and relapse again. When we started doing maintenance ECT, they referred her to us. We put her in a maintenance ECT protocol. She's not been hospitalized for 5 years, and this Monday she got her 144th treatment. And she has lived in the community. She lived with her daughter. She works in a shop, and she's 84 years old.
Ed, not only is ECT so amazingly effective, but it's always amazing to me how safe it is. My experience with things has always been that one of my main rules of psychiatry is anything bad that can happen will happen to me. It seems like that ECT, which one would think would be kind of intuitively the most risky, is in fact the one that I've never had difficulty with, have never had the first problem with.
The risk of mortality is about 1 in 10,000. I think that's an old statistic. I'm not sure that would hold up today. The most common side effects are post-ECT confusion, occasionally post-ECT headaches, muscle soreness. The more serious side effects you're concerned about, which are rare, are myocardial infarction, a stroke, broken bones. But in today's treatments, where they're continuously oxygenated, they receive succinylcholine as a muscle relaxant, these events are really very rare.
The biggest criticism and the reason why most people don't want to use it and everybody's up in arms against it has to do with memory loss. Memory loss. And, I'm of the school that believes that there's a transient confusional state and no memory loss. But apparently this continues to be a major issue.
Basically, all the studies that have addressed memory loss, basically by looking at it at various time intervals using fairly sophisticated neuropsychological testing, has found no memory loss. However, there is this unexplained subjective sense that some patients have. But the fact is, once you stop ECT, within 2 to 4 weeks, memory normalizes. And so I believe in these patients that are claiming profound memory losses that have persisted, have other personality issues going on, and that memory loss is just not consistent with what we know about ECT. Vladimir Horowitz was able to go on and continue an outstanding career after he received ECT.
The question arises often about unilateral versus bilateral application of the electrodes.
Just when you think it's resolved, it's not resolved. I think what the APA task force had concluded is that we should start out with right unilateral because it's less cognitive impairment, and then if a patient doesn't respond in 4 or 5 treatments, we would then move to bilateral. But there's a number of psychiatrists who do it to continue to question the efficacy. Is right unilateral really as efficacious as bilateral? And that's sort of been an undercurrent, and there was an article published in the New England Journal of Medicine by Harold Sackheim, who really is one of the pioneering researchers, I think, in the country. He had 4 groups: high-dose unilateral, high-dose bilateral, low-dose unilateral, and low-dose bilateral. And what he found was that the poorest results occurred with the low-dose unilateral. The next poorest response was the high-dose unilateral, and that the high-dose bilateral was by far the most effective treatment, and that the low-dose bilateral was more effective than either cells of the unilateral. And my own personal preference is to just go straight to bilateral, so there's no question about efficacy. These are very depressed patients, and I would only use unilateral if the patient has a job in which they're very concerned about memory impairment, or if the patient may in fact have a mild dementia, mild to moderate dementia, and you want to try to spare more confusion.
Has the workup for the ECT patient changed?
Well, actually, I think it's decreased. I mean, we used to routinely, for instance, get spine films. Well, I think that's been discouraged. And really, the basic workup now is, and this is right from the task force report of the APA, is really just electrolyte, CBC, and EKG. And then any other workup beyond that would be indicated by the patient's complaints or history. We do want an anesthesiologist to see the patient to make sure that they're an acceptable risk to undergo anesthesia. Another part of the workup which we do is we do get a psychiatrist's second opinion to say that the patient is appropriate for ECT. I think there's a belief that psychiatrists do this because it's in their economic self-interest, but in fact we turn down about 25% of the cases, and a lot of it has to do around inappropriate treatment, we think, a misdiagnosis. So not every patient gets rubber stamped.
Yes, Jeff.
Yeah, I think it's terribly important when ECT is presented to a patient that the patient come away with the idea that it is not the treatment of last resort and that it is merely a treatment along a course of many treatments. Should ECT fail, there are other approaches that are available to continue to work on the depression, because a lot of patients think if ECT fails, it's all over and I might as well go kill myself.
One of the things I hope we say in this tape is that it's not useful to divide depressions into biological and non-biological, and that all depressions are biological in the sense they affect your mood, your appetite, your concentration, energy level, etc. And that the decision to use medication is usually based on the severity of the symptoms, the patient's preference, but that does not preclude psychotherapy or the importance of the psychological context of the illness.
I would propose that we do away with the term psychotherapy and psychopharmacology and say that as psychiatrists we can do physiology-based interventions and we can do language-based interventions. And I'm speaking out of just my personal view on the things. I'm not sure we can survive as a field that only can work with physiology.
This myth that's gotten in the literature and also in practice that there are biological and non-biological depressions, I think is not useful, and also it trivializes depression.
It's interesting how in medicine, no cardiologist would talk to a patient who has angina, not mention diet and weight gain and lifestyle, and bring in all these other issues. So while that is happening in medicine and they're sort of moving to more biopsychosocial model, we're being forced by forces to actually move away from that model.
Well, I think it's also an issue of how do you define recovery? Because there are many patients who will be on a medication and they're sleeping better and their appetite is improved.
Yeah, I feel that's better, but my life is still a mess.
So that's where psychotherapy would be the intervention, and you have to evaluate what is the nature of the psychotherapy, if any. I think there's a generation problem, and that has to do with the basic training.
The fact is that yesterday's practitioners are decade related. The 50s is pure psychoanalytic. The 60s is behavioral and social. The 70s is biological. The 80s is interpersonal, cognitive, brief dynamic. And if you were in training in those years, that's what you learned, and so that's what you come out and you do. And tomorrow's psychiatrist is going to have a smorgasbord that they can call upon and do. Let's talk about the varieties of psychotherapy, flexibility, and the use of multiple methods. I've listed 9 kinds of psychotherapy: interpersonal, family, marital, psychodynamic, brief and long-term, cognitive, behavioral, and group. That doesn't mean that's all there are, or that we're going to even cover all of these. Myrna, how about if you start by telling us a little bit about interpersonal psychotherapy?
The whole idea behind interpersonal psychotherapy is that depression, whatever its cause, and it makes no claim about biological or psychological, occurs in an interpersonal context. And that if you understand that context, you can begin to understand the association between the changes in mood and affect and what's going on in the environment. The idea is also to reduce the symptoms of depression, and that's done primarily through diagnosis, through making the symptoms, the diagnosis, understandable to the patient so they gain some mastery on it, and to then determine the relationship between the symptoms and what's going on in their environment, and to help them in the problems in the environment or their social functioning. And it makes no claims about personality, although it recognizes personality is important in enduring aspects of affect, but that's not the idea behind a brief treatment. Now, in the first phase, what happens is very much what I described as what I think is the minimum that should be done in treating depression. You make a diagnosis, you explain the diagnosis to the patient, and then you try to determine the relationship between the development of the symptoms and their environment. And there are 4 problem areas that seem to be most common in depression, and those are unresolved grief, role disputes, usually they're marital disputes, role transition, new job, move, change in status. And the last one is what we call interpersonal deficits, problems people have in initiating and sustaining relationships, and that's the hardest problem area to work in a brief treatment.
I'm not sure about how much IPTA actually do, but how much caring, what is the caring quality? What goes on between you and the patient?
Well, the relationship between the patient and the therapist is not explored. You don't explore the transference, but one has to be an empathetic therapist. And I should make the point that reading the manual and learning how to do IPT doesn't teach you to be a therapist. You don't know anything about timing, you don't learn about listening. What you learn is to adapt those skills to a brief treatment, and that's a very important point to make.
I wonder how similar this is to the Masters and Johnson sex therapy model, where they're explicit manual-driven therapies that very few of us actually do.
Well, but they rely on behavioral techniques, and I don't hear that in the IPT.
No. And there's a lot of people doing IPT now. There's a lot of requests for training. Remember, IPT was developed originally by my husband, and Jerry Claremont was a very good therapist. And what he tried to do was formalize what he thought should be done and what he did in the treatment of depression. So it doesn't come out of the blue. And therefore, I think it's probably many aspects are done by therapists. It's not hard. If you're an experienced therapist with a lot of experience with depressed patients, it is relatively easy to learn. The most difficult part to learn for an older therapist who's trained as an analyst is that you do a very explicit diagnosis in the beginning. You begin with the diagnosis.
Yes, Jeff.
How do I go about learning IPT in a way that will allow me to be as effective with it as the people in the controlled studies?
For experienced therapists, they learn it very quickly. Now, I guess the way you'd begin is just by reading the book, if you had no one to supervise you. And right now in training programs, in residency training programs, it's becoming fairly standard, even at Columbia. And we're going to start developing a training program working with David Barlow probably. Last year they hired one of Jerry's students, John Markowitz, to train some therapists, and I'm doing some supervision of residents. And I know Pittsburgh has training, and I think UCLA does, so it's becoming more common. We're making a training tape that you'll be able to eventually purchase, and it will show you how to do it with patients. The next generation of residents will know how to do it.
And how does it stack up against cognitive? I mean, these are going to be the two psychotherapies that people are bandying about as effective treatments for depression. How learnable is each one, and who should be doing what?
I think that's unfortunate if those are considered the only two. Those are two that have been tested in controlled clinical trials, but I'm sure there's other ways to skin a cat that are probably as effective. Some may even be more effective. Cognitive therapy is behaviorally oriented, and it attributes the depressive symptoms to a cognitive misperception of the environment. Let's take Vincent Foster. It would have said that his perception of the Wall Street Journal article and his performance was negative cognitions, and they would help him to change those cognitive distortions. IPT would have said he has a depressive illness and it's related to a role transition. And the role transition was his change of jobs, and it would have tried to find out what was the symbolic meaning of his change in jobs and his performance. That's basically how they differ.
Now, if I want to learn one of these techniques, which is easier to learn, or does that vary with the individual?
Usually, psychiatrists, in my experience with the residents and with the junior faculty, psychiatrists find IPT more consistent with their training. Psychologists find cognitive therapy more consistent because psychology training is usually more behaviorally oriented.
I think there are a couple of things in response to your questions, Jeff, that are important. One is that most of us do a little bit of IPT and a little bit of cognitive without knowing it or labeling it. Cognitive reorganization, or telling people that what's real and what's not real in terms of their perceptions, is a very important thing that we all do, more or less. What I think is important about studying these two techniques is the therapist becomes more flexible, has to give up certain basic systems that they've developed over 5, 10, 15, 20 years and begin to think a little differently. Myrna said, well, the first thing to do is make a diagnosis. For those of us who were taught diagnosis doesn't matter, just start to treat, you have to make some shifts in your basic system. That's a good thing to do because it's important to incorporate the best of these treatments.
They should anyway. It shouldn't be a cookbook.
Right.
See, my concern is that a little bit of IPT or CBT is analogous to using 25 to 50 milligrams of a tricyclic to treat depression. You sort of think you have the right treatment, but you're not really applying it in a way that's been shown to be effective.
Well, that's probably true, maybe. We need to have more training programs. There are more cognitive therapy institutes around, and we need to have certification.
Yes, Taylor.
I think managed care is going to probably make interpersonal therapy and cognitive therapy much more prevalent because it's time limited, it's specific, you can do quality control. The managed care companies are going to love it.
Yeah.
And I guess the problem with the therapies that we were taught growing up, like analytically oriented therapy, it's not specific, it's not time limited, and the managed care companies are going to go crazy with us.
That's your biggest fear is non-specific. That's unfortunate because for some disorders it's life-saving.
You know, one of the really fascinating things to me is the kind of mind-brain psychology-biology interface in all this. And, you know, we know from Ellen Frank's study that once monthly sessions of IPT prevent relapse, you know, and there's the implication there that by focusing specifically on the interpersonal issue, you affect the brain chemistry. And you know, that's really a kind of cutting-edge issue that I find fascinating in all this.
That's one of the goals of biopsychosocial treatment. I'd like to move on to family and marital and ask you, Griff, to tell us a little bit about
Well, I think that with family, marital, cognitive, behavioral, and interpersonal all qualify as brief therapies. And people ask me, if we're coming for family therapy, how long will I be coming? I say on the average it's probably like 4 to 20 sessions. You know, maybe every other week, maybe once a month. And there's a lot of overlap in terms of what actually happens in the room, so that I don't think you can create a clean distinction where you're either doing this or you're doing that. Conceptually, I think family systems would be probably closer to interpersonal than to cognitive behavioral. But I think the main difference would be that in both cognitive behavioral and interpersonal, the individual patient is in the foreground, and the family is in the background as a significant entity influencing things, whereas in family systems, the relationship context of the symptom really is what is in the foreground. It's sometimes, I think, a misconception about who you want to be in the room. I don't necessarily want blood family. I think nowadays most family therapists would want to get that group of people who are involved around the problem, whether they're blood family or not. That group of people involved in the problem. For depression in particular, I think couples therapy is an ideal model. And that's not what I was trained in, but nowadays is what I do whenever I have the opportunity. In part because depression seems to be so related to attachment issues anyway.
Well, there is a cultural factor among Hispanics. Everything happens in families. It's you cannot treat a depression without the family context. Seldom a Hispanic patient comes alone. Quite often they not only bring the wife but the children, and if other members of the family are in town, they also come. And they also
without you asking them.
Well, no, they are not invited. They are there.
They're not invited, but they come in.
Yes, that's right. And soon you learn that you are not the decision maker. Somebody else. And you find out who is the decision maker about treatment. You may be able to be effective.
Yes.
I think marital therapy makes a lot of sense conceptually. Because you talk about psychotherapy, we're hoping to train the patient in certain skills that he or she will carry out into their own environment. In marital therapy, you're taking that person and helping train the skills with the person that's most important in their life. And if you can do that, I think you've done an awful lot for a patient. I think it makes a lot of conceptual sense.
The other side that I've noticed, and I'd be interested, Griff, in your response to this, is if the depressed patient plays a certain role in the couple or the family, and if improvement then changes the whole dynamics of the family or the couple and the impact that has in terms of the patient getting better.
You have the question that if depression were to improve, would there be any things at all that you would worry about? And many things can turn up, all the way from if this has been a couple relationship mainly organized, say, around the wife caretaking a depressed husband. It can threaten the relationship. if the husband's depression has given a wife a chance to get out, develop her own life, have a job, more of a place in the family, it may be a threat to go back to the old ways of doing things if it was a very traditional patriarchal relationship. These things can be identified, and once they are identified, you can plan ways to get around them.
What happens is assortative mating. You turn up other patients. We found that we adapted IPT for conjoint marital therapy because we felt that when there was marital disputes, we were only really getting one half the story. So we started bringing in spouse. And that really changed our perception of where the problems were, and we turned up that a number of the spouses were also depressed.
I think one of the interesting things that happens too is you almost become like the psychiatric general practitioner for the family. And I'm thinking of a woman that I've treated, and then saw her and her husband together for a while, and the daughter wanted to come in and talk to me, and now periodically different ones will call me, and it really ends up, not only do you become like the psychiatric general practitioner, but it has a lot of preventive qualities to it too.
At least for me, leads me to look at the giving of medications in a different way. You know, rather than giving a medication to treat a disease, it's more using medications to create new possibilities for relationship and dialogue between people.
The other thing that I think is important is the tradition of not keep bringing the family in that we have in psychiatry, mostly in psychoanalytic circles. There was a kind of keeping the family out. And my personal anecdote is that when I finished my psychoanalysis, I was terrific. My wife was depressed. So she went into psychoanalysis. It's a very costly system. But let's move along to the psychodynamic approach, and I'll ask Glenn to start us off on this.
Psychodynamic therapy is the most commonly practiced form of psychotherapy by United States psychiatrists, although it hasn't been systematically studied. And of course, for research, it's extremely important to have manualized psychotherapies. However, as with many other situations, it's a long way from the research setting to the clinician's consulting room often. And what you'll find, I think, is that flexibility is a keynote to being a successful psychotherapist. In fact, two findings from the Menninger Foundation Psychotherapy Research Project that both Wallerstein and Horwitz reported was those therapists who had the best results had the most flexibility in their technique. Those with the worst results were the most rigid in their technique.
All those different therapies. Should I be talking about my childhood or my marriage?
There needs to be a kind of flexible shifting according to what the patient needs. And, you know, I was trained as an analyst and a dynamic therapist, and when I started reading the cognitive therapy literature and the interpersonal therapy literature, my reaction was, oh, I've been doing that, you know, or I've been doing that. And I found a tremendous amount of overlap. So I think if we think in terms of a pure psychodynamic entity that is untainted by interpersonal or cognitive therapy, we're probably not talking about the reality of clinical practice where all of them have a good deal of overlap. One of the great advantages, I think, of a psychodynamic framework, or a way of thinking, is that the transference, countertransference developments in the relationship of patient and therapist are a kind of in vivo recreation of the main relationship problems that you see outside the consulting room. I remember I hospitalized a 64-year-old minister who was extremely depressed and suicidal, and I'd meet with him every day in the hospital, and every time I said something, he would go, yeah, just barely audibly. And at first I wasn't sure if I was hearing the right thing, you know, and I'd talk some more, and he'd go, yeah. So finally, I found myself getting very irritated by this. No. I thought this was quite rude, and that he was sort of thumbing his nose at anything I said, had no interest in listening to me, and so I finally brought up that, you know, I know that you, whenever I talk, that you say, yeah. Have you noticed that? He said, yeah. And so then, this guy was in the hospital, and I brought his wife in.
Get him in.
No, I brought his wife in, and I had the wife and the patient meet with me. And I said, you know, I've noticed that your husband always goes, yeah, whenever I talk to him. And she said, he does the same thing to me. It drives me nuts. And I said, well, you know, I had a similar reaction. It started to irritate me, too. And so then we had a marvelous opportunity to help this guy see the unconscious aggression and anger that was coming out and the way he related to me, his wife, his kids, and getting him to look at the aggression was kind of a breakthrough in the therapy. We're also treating him with medication, of course. But if we tune ourselves into our own reactions and what the patient's doing to us, we really have a marvelous bridge to helping the patient work on interpersonal issues outside the therapeutic relationship.
It's similar to Malin's triangle of insight. You have two of the three prongs of the triangle of insight there. The other thing that was lacking was the past part of that. And I'm wondering if maybe in the managed care era that the brief dynamic psychotherapy may be the salvation of psychoanalysis.
Didn't Liborski do that? Has anyone looked at his manual for...
Yeah, he's manualized expressive supportive psychotherapy.
But that's not psychodynamic. I thought
yes, it is.
Yeah.
It's definitely psychodynamic.
It's a kind of psychodynamic. What we have to do is, I think one does not have to do classical psychoanalysis to utilize psychodynamic concepts in the overall care of patients who are depressed and whose depression is interfering, whether we put them on medication or not. And there's some we will and there's some we won't put on medication. But regardless, those basic psychodynamic principles, which Malin has called the triangle of insight, I think does have to do with the past, the present, and the transference, and having some sense of how you approach those three places in the person's life.
Paul, you're also speaking to a fundamental psychodynamic idea, which is that treatment is about active verbs, what the patient is actively doing, not passively experiencing the effects of others and chemicals and things like that. While that may be going on, there's also something that the patient is doing in relationships to other people, something he's doing to repeat the past, object relationships, that you are helping the patient to see. Something he experienced as passive, you helped him to see he was making an active contribution to it.
Well, no matter what treatment I do with a patient, whether it's family or a couple or individual or whatever, the patient always starts by blaming somebody else. And then I interpose a psychodynamic concept that I'm only here to work on what your participation is, both personally, interpersonally, and intrapsychically. What are you doing? Yes, Taylor, you want to say?
A case that was a woman who was depressed, and I tried her various antidepressant regimes and really got minimal response. And then I started trying to do psychotherapy with her, was getting nowhere. And the only thing she kept talking about was her marriage. And her husband wouldn't come in. And so I was kind of stumped, and I didn't know what to do. So finally I got her to talk about the argument she had with her husband. And then I did which I guess would be called targeted behavior therapies. I taught her how to argue with her husband. I taught her how to say when her husband was getting off track, when he was putting her down and not addressing the issues at hand. And her depression lifted.
And then he came in.
He never came in. He never came in.
I'm kibitzing, but that's it.
He may have left. I mean,
That would be defined as a marital dispute, and there's be classic way of handling that written down in a manual that should do very well in psychotherapy. Without the spouse, it does better if you get the spouse in, but usually you can't.
Arnie.
In the pharmacotherapy portion of our meeting, we talked about different forms of medication treatment for different situations, different patients. I wonder if we might focus on whether in particular forms of psychotherapy are geared toward individuals with certain profiles. Something that has not come up yet.
There's a little bit of data on predictors of IPT, but they weren't the people that you would have expected.
So we talk about depressions that are very difficult to treat and resistant to treat and require complex treatments, but there are forms of depression that are really pretty easy to treat. I mean, they really do exist. And Lauren, it seems to me like that the NIMH study sort of showed that indeed mild to moderate depressions, clinical management alone, A lot of them got better.
They did very well. They got better, but they didn't stay better.
What the NIMH data showed is it was sort of like the rich get richer. Those with mild cognitive impairment do better with cognitive behavior therapy. Those with mild social impairment do better with interpersonal therapy. I also think for dynamic therapy, you would want to consider things like psychological mindedness, motivation, introspective capacity, the wish to view the illness as growing out of a psychological matrix that can be understood. And that gets back again to this consumer approach that we've talked about a lot. Is this what the patient wants to look at as part of the treatment process?
Many depressed patients do not like depressed patients, hate to be depressed, and hate to be classified as psychiatric patients. They try to get rid of that situation as soon as possible. At least in some of them, I believe that interferes with compliance with treatment, and as soon as they can, they abandon treatment. And I don't believe we have solved it.
Unless you step back and realize this therapeutic zeal may be misguided and may be hurting the system, or take a look at the countertransferential feelings, you're not going to be able to really approach the patient with some degree of empathic distancing that's important. There are a lot of treatments that don't necessarily analyze the transference, but utilize the transference. And maybe, Glenn, that would be, just a couple words would be helpful on that issue of...
Sure. I think that I would consider IPT dynamically informed supportive psychotherapy, and I know Myrna agrees with this because we've discussed it. And you keep track of the transference, and you use it in a way that facilitates the treatment. Just like if you're prescribing for someone, and they see you as an authority figure who knows a lot about what's going on, and they become very dependent and passive and do whatever you say, then that may help the compliance. Now, on the other hand, you have the opposite, where you notice that the patient seems to mistrust everything you say and rebels against whatever you do, and you have to take that into account by making the patient more of a collaborator, helping bring out the skepticism, without necessarily interpreting or analyzing the transference. Another phenomenon that I had with one patient that I think illustrates the transference issue was I was treating a woman in psychotherapy, and because she became more and more depressed after about 3 or 4 sessions, I added an antidepressant. Well, she didn't get the prescription filled for 3 weeks in a row. And the 3rd week I said, "What's going on?" And she said, "I have the feeling that you don't want to talk to me anymore. And that's why you're giving me medication. You're sick of listening to me." And so I said to her, "Is there some kind of history of this?" She said, "Yeah." She said, "My husband sent me here because he said he was sick of listening to me." And then, indeed, the father also had never been much of a listener or talker, and so she was re-experiencing me. And here's a triangle of insight: as the father and the husband, a man who really wasn't particularly interested in what she had to say, and I was getting rid of her by giving her a prescription. And when that came out, then she did actually take the medicine and complied, because we got that out on the table. And I also offered reassurance that I'm still very much interested in listening to what you have to say.
Yeah. And during the treatment, there is a lot of feeling of enormous frustration on the part of the psychiatrist that he or she is not able to make the change that's necessary.
When I start feeling very frustrated and irritated, this patient is kind of non-responsive and not really interested in getting better, I find that what I am feeling is emblematic of what family members feel. And if I talk to them, they'll be frustrated. They'll be irritated because this person isn't getting better. And often there's an internal object relationship in the patient that is being externalized and acted out with me and the family that's worth taking a look at, Why is the patient so resistant? And one of the frequent things you find is that depressed people feel they deserve to suffer. They shouldn't get better. They really should be punished because they've been guilty of terrible sins, crimes, so why should they get better? And that dynamic is often beneath the apparent failure to respond.
I think your point about the family having the same experiences as you is another reason that you may want to talk and bring in the family. There's also the issue of your recognizing the underlying dynamics, which I think are really very important and raises the next question and perhaps the last issue around psychotherapy, and that has to do with the comorbidity of personality disorder, axis 2 disorders, where you are going to do a long-term intensive psychotherapy or psychoanalysis, and you're going to have the person on drugs or not, and who monitors the drugs, how do you monitor the drugs, and how do you fit that into a classic or not so classic psychoanalysis? How's that for a question? Glenn?
Well, nice easy question. I do think that those patients with personality disorders, and the most common ones you see with depression are borderline, obsessive compulsive, dependent, and sometimes avoidant. When you see these people with depression, they're going to need psychotherapy, almost for sure, because the personality style, the character style, often serves to sort of defeat the treatment for the depression, because they are perpetuating certain kind of pathological patterns. There's an important role for long-term, detailed psychoanalytic work with these people. And my feeling, Paul, is I think a rather controversial one, that it's much better to have the transference focused in one person, in one relationship. So I prescribe for people that I'm treating with psychotherapy or psychoanalysis. Not everyone agrees with that. But I think if you start splitting up the transference, especially with borderline patients, what you'll have is an idealized pharmacotherapist who's very giving and caring and responsive, and then you have this stuffy therapist or analyst who's not very giving and is frustrating and non-gratifying, and it's a setup for a splitting operation. So I really think that the two functions should be combined in one person whenever possible. And again, we get back to this issue of managed care, where often managed care firms are dividing up these functions and saying a psychiatrist should do prescribing and then a cheaper person, like a social worker, should do therapy. And I think that's a setup for problems.
Well, you don't get any controversy from me, because I also believe that the psychoanalyst or psychodynamic psychotherapist should give the drug.
Good.
And that brings us to treatment planning, which is one of the most important aspects of this discussion, because it brings us back to managed care and the case management problem. This might require medication and a therapy, whether it's psychodynamic, interpersonal, group, or somatic, like ECT or light therapy. Whatever the treatment, there is the management of the patient above and beyond the implication of a single kind of therapy. Your concern about the managed care company, which is a very important concern, is that they have, more than anybody else, made a formula out of the treatment. The success of this tape really depends upon psychiatrists understanding there is no formula for what appears to be the simplest diagnosis in psychiatry.
When the guidelines for the practice guidelines for depression were discussed, there was quite a debate about psychotherapeutic management. So we have to agree that every time we talk about depression, we are going to talk about a series of measures that are taken in order to provide the psychological backup to giving medications to the patient. So there are going to be those measures like supportive interaction and clarification and explanation and education. So when we start talking about medication, we take it for granted that all of that has happened, that the measures of psychotherapeutic management for the patient are in place, and now we are prepared to start the medication, knowing that without those psychological measures, the medication may not be as effective.
There's a kind of magical quality if you give him a prescription. You don't have to talk to him, you don't have to think about the symptoms, you don't have to address the problems of his interpersonal difficulties, his intrapsychic difficulties, whatever family difficulties, the job difficulties. All of that is in that envelope with that prescription. It's like a magic, and there isn't a magic.
I think any discussion should say something about the psychological management of patients, because whether or not the patient who's getting medication gets psychotherapy, they need to have some kind of monitoring. They need to have some explanation of the medication, the side effects. There needs to be a continuing dialogue so that if the patient wants to adjust or needs to adjust the dose, there's freedom to call. And they need to be given some kind of hope. And this doesn't need to take a long time.
I'd like to say something a bit more radical. I think that we psychiatrists make far too sharp a distinction between psychotherapy and pharmacotherapy. I think that when I'm prescribing, I'm always doing psychotherapy also. I think psychodynamically when I'm prescribing medication in terms of resistance, the transference, my countertransference, the principles of psychotherapy apply just as much to pharmacotherapy. I call it dynamic pharmacotherapy. I'll give you an example, in terms of resistance to taking medication. A woman I had on imipramine was not responding, so I added a little bit of lithium as an adjunct. She seemed very reluctant to take it, and sure enough, when it came time to do a blood level, she told me that actually she wasn't taking it. And so I explored that with her, why wasn't she taking what I prescribed? And with a very emotional voice, she says, "I will not be tied genetically to my mother." Now, on the face of it, that's an absurd statement, of course. But her mother had been bipolar. Her mother had been bipolar. Her mother had committed suicide. To her, there was a meaning of taking lithium. That I was saying she was like her mother, she also was bipolar, and she too would commit suicide. And so we had to explore and work through this to get her to comply with the lithium I prescribed. And so, that's why I say that I'm always thinking that I'm doing psychotherapy when I'm prescribing, and I think for research purposes we separate the two more than is realistic in actual clinical practice.
I think that we have to understand what treatment planning is in the outpatient or inpatient or any other setting, and how to make the best plan for the patient.
I just wrote down 7 things that I would think a minimum requirement would need to be done to assess whether the patient is depressed and whether you should begin treatment. And I don't think that would be very controversial.
Read us your 7.
Well, this is probably going to seem, it's simple, but if this patient comes in, there needs to be enough time to do an assessment of the individual's symptoms, both current and past, including suicide. There has to be time to make a diagnosis, not only of the depression, but also of comorbidity. For example, panic and depression is a very bad mix. There needs to be family history. There needs to be some involvement or discussion with a significant other, if possible. There should be some understanding of the interpersonal context of the illness. How did it begin? When did it begin? Is this the first onset? This information has to be conveyed to the patient, both what the diagnosis is, the prognosis, and also an explanation of the treatment options. I don't think you can do that in an hour. Maybe you can do it in 2 hours. But that should be a minimum requirement, and there should be a minimum payment to get those done. And also there has to be a medical evaluation, if they're over 40.
For me, one of the earliest decisions to make is who should be involved in the conversation in deciding the treatment plan, because the constitution of the group of people that is involved will determine the plan you get. So should it be spouse, should it be adult children, should it be people from work? We do all of those variations, but you get different layering of different kinds of interventions depending upon who gets involved. And certainly at our university inpatient unit and outpatient, we do much more of that rather than simply it being a private decision between the psychiatrist, patient, and insurance company.
You use who else?
Usually develop it out of a conversation with the patient. Who might need to be involved in this process. I think if we're looking primarily at acute improvement, say on items on the Hamilton Depression Scale, we'll mostly be talking about medication. But depression has a very devastating effect on marriages, family relationships. Those don't improve, particularly if medication is all that's offered. Depression can have a very devastating effect on a person's sense of personal agency. If medication is not handled in the proper way, that actually can get worse instead of better with a prescription.
We had a nurse referred to us who had been treated in the managed care by a managed care company who had and she had a depression, allegedly a biological depression. She was put in their step-down unit because she wasn't suicidal and didn't need acute hospital, and they put her on an antidepressant and sent her home with a little improvement. And to again emphasize exactly what Glenn said, as soon as she got home, she stopped the medication. And 6 months later, she ended up in our hospital with 10 days left on her insurance benefit. And I saw her, not only, I started her back on the medication, but also started seeing her every day in therapy, because she was a very bright, insightful nurse, and I would see her for about 45 minutes a day. She started talking about her marital problems, something that happened at work, which was an extreme blow to her self-esteem. But the thing that she said to me was, "You're the first person since I have been sick that sat down with me and really looked at the whole picture and not just looked at pills." And I absolutely agree that you can't separate biology and psychology. We have to treat the person. The psychiatrists that are listening to this are going to say, where's he coming from? It's not like that in the real world. And how do we integrate what I think is good clinical practice with all the pressures that are occurring now in psychiatry?
One way to play along with this system is to actually, instead of saying there are no formulas, is to develop the minimum formulas that are required for one to treat someone with depression, given that if you didn't do this, it would be almost malpractice. And I think you could define some of those minimal things, like, first of all, that you make a diagnosis, that you explain the diagnosis to the patient, that you explain the treatments, the side effects, that you determine the interpersonal context of the depression, that you help the patient see the relationship between the symptoms and whatever that interpersonal context is. You have a minimum amount of regular visits in which you can continue to evaluate these issues and also see what the side effects of the medication are and whether the patient is taking the medication. You could argue that without this, the patient probably is going to drop out, won't take the medication as prescribed, and in the long run, they're going to come back again because there'll be recurrences, relapse. Some of the guidelines and some of the new psychotherapies have what you would consider the minimal requirements for treating a depressed patient, and maybe that's what ought to be looked at and expanded.
That's terrific, because making the assessment becomes the big item. And I guess that's the message we have to get across to the managed care companies, which is the varieties and the enormous need that Glenn has introduced, which is not to differentiate but to assimilate the pharmacology and the psychotherapy into a managerial statement called the treatment plan. Barney?
Yeah, just wanted to add that part of psychotherapeutic management has to be to help patients adjust to real-life exigencies, scheduling leave of absences from jobs, postponing crucial decisions in their life, helping the patient to deal with effects of his or her own illness on spouses and children, others in their social networks. These things cannot be ignored.
When you've got to sit down and explain it to the patient and the family, we're going to be methodical about this and systematic, and you're going to think it's slow, but it's really being systematic and methodical. What you don't want to do is 3 months down the road look back and say, what if I'd have left him on drug A 2 more weeks? You just can't allow yourself to get in that position.
That, plus once you're better, you have to be on this drug for at least 6 months. And I start that kind of education even before I write the prescription. And I think that helps with the patience and waiting for the response, as well as compliance later on.
And much of the time what we're really doing is collaborating and negotiating. I've got 2 or 3 patients that have had recurrent severe bouts of depression who, knowing full well they're likely to have one, still would prefer not to take the medicine. So we simply focus on trying to do early recognition of relapse. And I think that, I guess I feel like to a greater extent than I guess our tone of discussion would give it, that much of this choice lies with our patients.
I think Griff's raising an extremely important point that when you talk about maintenance therapy, this is the part of the course of the illness where the patient's psychological resistance really becomes a major factor. And if you can kind of get them to verbalize and talk about that and collaborate with them around that resistance issue, then sometimes you can get better compliance.
Spending $60 a month when you're feeling good and you're getting a few side effects you don't like, it's pretty tempting to discontinue treatment.
But it often does boil down to the fact that they will stop taking it, and they'll have to have a relapse before they're convinced of the need for maintenance medication.
I want to. It's helping. But I don't see how I can afford to keep taking the drug. I mean, nobody will pay for it, and the kids need stuff for school.
I think another undercurrent in this discussion is that managed care has geared itself to a mythical construct of mental illness.
That's
which
right.
is as
Unfortunately,
though
we're part of the myth.
I know, but what I'm saying is that the mythical construct is that mental illness is an episodic thing that flares up, you treat it, and it's over in 10 sessions. And, you know, if there's any fault of all of American medicine, it's that we've emphasized too much on cure and technology rather than on prevention. And you know, here we have most of our mental illnesses have some kind of chronic relapsing quality to them in which they need preventive, prophylactic kind of maintenance treatment, and yet the managed care situation is set up to deny the ultimate chronicity of most mental illnesses.
I think it's about 50% that have recurrent episodes, and there's about 10% who are chronic and become chronically depressed.
You sort of need to look at the epidemiology and who has relapses and who doesn't, and thanks to Myrna and Jules Onks and the Pittsburgh group, you know, we know that in fact people relapse a lot, and there's a lot of recurrent depression out there. And if you look at who does statistically, who has relapses, people who've had multiple episodes before, people who have had a long depression before they are treated, and people who have an early age of onset. Those folks, you've got to seriously look at maintenance medicine. I would also think people who have had psychotic depressions, two, say, back-to-back psychotic depressions, I think those people should be looked at for maintenance medication. People who have significant suicidality for 2 episodes consecutively, I think you need to look at them for maintenance medication. I don't think the rules yet are hard and fast, but there's obviously groups that you need to look at.
Many people would say to me, come in and see you once a month, I feel fine. Why in the world am I doing that? I'm using up my health care benefits that I may well need if I get sick again. I think educating patients and significant others to recognize early warning signs is extremely important.
And you have to do that early in the game, because this issue of depending on your insurance and your insurance being terrible in no way protects you from exactly what you're saying, Myrna, and that is that the recurrence will in fact kill you if we allow that to be part of the consideration.
But Jeff, I think it depends on the patient again. It's an individualized matter. And if you have somebody who really doesn't want to take maintenance medication, or somebody with significant interpersonal problems, a monthly session of interpersonal therapy would make a lot of sense, because we have data to show that it prevents relapse.
I guess I'm really a believer in using whatever works and then taking credit for it afterward, I think, is probably what I do best. I guess I agree with really what Myrna was saying to begin with. I think you've got to understand basic psychodynamic principles or you're just lost. And I think regardless of what you do, you have to be able to do that. And reassurance works. I think a support system works. I really think giving people some comprehension of what they're going through works. So that when they come in, often when they come in to see me, they're completely bewildered and terribly frightened by this horrible event that's been placed upon them. And I think just to give them a comprehension of what's happening is tremendously helpful for some people. Other people who are more passive, I think to give them the notion that, yes, you're going to get better, and I'm going to help you get better. What do people think here around the table of the appropriateness of using psychotherapy alone as a treatment in patients who have moderately severe or severe depression? You still see that done in some places.
What do you think?
Well, I have grave reservations about it, and I think what little hard data there is, such as the NIMH study, certainly points that it probably isn't the best thing to do.
I agree.
I think it probably isn't, and this, I would think that the decision for medication should be based on the severity of the symptoms. But there are some patients who won't take medication, and there are many women who won't take it during pregnancy, and certainly during nursing they can't.
I'm speaking more really about the physician's choice as opposed to the patient's choice.
Yeah, well.
Or perhaps the non-physician, perhaps, say, a mental health professional who's not a physician.
Well, we've heard some people say that you should delay the onset of the medication until after you've seen certain things occur. I personally think that if you have a moderate to severe depression, that it's a deprivation to not put them on medication for whatever purity reasons you feel you have to hang on to. Yes.
I think you have to look at the social context of patients in. Obviously, if patients in a competitive employment situation, they may get not promoted or fired or who knows what else while you're waiting for psychotherapy to kick in. If you've got somebody who's moderately, severely impaired, I think you have to move quickly.
Purely from a practical risk management standpoint, it doesn't make much sense to treat somebody with rather severe depression without medication. I think you're setting yourself up for liability.
Yeah, I think just 2 points that I think I found helpful. One is, in making the decision between do we proceed with medication or without, just to ask the question, what are the basic requirements of doing any psychotherapy? You need to be able to maintain a relationship, you need to be able to stay in conversation. And since depression does impair attention, it does lead to a preoccupation with one's inner thoughts, it does affect memory, it's an important question, do I have the conditions under which it's possible in a severe depression to conduct therapy? The other thing I wanted to mention, though, is that I think increasingly we talk about prescribing medications, but it's more and more a collaborative exercise, and I think what does the patient desire? It's one of the most important indicators, especially in the milder group.
Glenn, do you want to say anything
I
about
don't think
that?
there's any evidence to support the idea that someone on antidepressants is less amenable to psychotherapy. In fact, quite the opposite, that all of the data indicate that people actually do better in psychotherapy on antidepressants than when they're not medicated.
What's the mildest form of depression that's worth treating with antidepressants? And we've been dealing with that. The other side of that is what is the most severe form of depression where it's legitimate to withhold antidepressants. And I think that the trend over the years clearly is that, as Dr. Richardson was saying, if there's functional impairment, even if it's mild, antidepressants should not be withheld. But I think this is fairly controversial for a good number of practitioners who prefer to start with a course of psychotherapy of one sort or another and add antidepressants if they don't feel that there's adequate improvement.
The issue of treating mild depression with antidepressants is complicated. I suppose everybody here has thought to themselves, gee, maybe I should try out these things just in case I can revamp my personality a bit and be a little more outgoing and brighter and enthusiastic and positive. If you look at outpatient studies of treatment of depression, when you get down to mild depression, everything works. Everything works better than nothing. The waiting list does least well. But I know when John Grice at our place was doing running as a treatment for depression, running worked as well as psychotherapy. And when they added a meditation group, meditation, running, and psychotherapy all worked better than waiting list. So to say that everybody who walks in with mild depression should be on antidepressant is fine. Most of those people are going to get better anyway.
Well,
I think the common factor that everybody got, including the running group, was a caring, empathic relationship.
Sure.
So I think that what we can say is with mild depression, a therapeutic relationship is therapeutic.
Paul, can I introduce some psychosocial stressors into this discussion, or do you want to?
I'm eager.
Okay, well,
psychosocial stressors.
What I wanted to say was
stressed myself.
Many of the psychosocial stressors that we've been talking about all day, the retirement, is one of the biggest role transitions. And one of the other things that you see very frequently in retirement situations is that one spouse has not been working and the other one working. So then when the one retires who's been working and stays home, the other one starts getting very depressed and upset because they have to have this person in the house with them all the day.
I don't think we should gloss over the retirement issue and the fact that the loss of status becomes a major issue.
That's one issue. The other is the tremendous connection between self-esteem and work, and the plummeting of self-esteem when you're not working anymore. You have no identity, no meaning to your life.
You'd be proud of me. I cleaned up the apartment. Don't know why. no one comes to visit.
You know, while you talk about losses, I think an important loss that we have to consider in all our older adult patients are the sensory losses. Just improving their ability to hear, their ability to see, often will help with their depression.
Also, at some point there is a subtle conscious, unconscious, realized or not realized transfer of power from the elderly person to their child. It's a very important part of what happens to an older person or a sick person. And again, a personal anecdote, when my father was very sick with cancer, his terminal illness, at some point he said to me, I don't know how to fill out this insurance form. And he had filled out hundreds of insurance forms. So essentially he was saying, I'm turning things over to you. That was a very painful thing for him and a very difficult realization for me, and so it brings in the whole family issues again of how the family reacts to the loss of power and status. And then there's the problem of the person who's had a significant loss, no matter what their age.
It's been nearly a year since you've been gone, and I still cry all the time.
Well, let's begin by pointing out that the distinction between the so-called reactive and endogenous depression is not very useful anymore. It's like the distinction between biological and non-biological depression. I don't think that those are useful clinically, and that you really have to go according to the severity of the symptoms. It is true that somewhere around a quarter of bereaved patients will have a major depression, and with all the symptoms diagnosable right out of DSM-4. And I think that we have to use good clinical judgment when we're evaluating a bereaved person. One of the old saws that is still somewhat useful, I think, is that the person just suffering from grief or bereavement without major depression does not have the profound self-depreciation that the depressed person does. And I still think that's a useful kind of rule of thumb. You know, when someone is really saying, I am a worthless person in the midst of bereavement, then you start thinking about major depression.
Without worrying about 2 months, 4 months, 6 months?
Certainly, the longer it goes on, the more you think about complicated grief reaction and a major depression. Initially, it's often very difficult to tell.
I think the classic work on this was done by Sid Zizek out of San Diego with an elegant study. And indeed did find, as Glenn said, 25, I don't remember the exact numbers, but 25-30% of people did in fact come up with a major depression by the second month. And when he followed those people for, I think it was 18 months, most of them continued with that major depression. It didn't resolve on its own. So this is not something that watchful waiting perhaps is the best treatment for.
We have to pay attention to the condition of their life in which they've had the loss. A person with no children who has been married for 30 or 40 years and loses a spouse is a risk patient more than a person who may have 2 or 3 children, a good social circle, people are supportive, and that's a very critical part of this. When my wife died, my 3 children and friends, I didn't eat alone for the first 6 months. I never had a meal that I was alone. That was a support system.
I was thinking about that personally myself, that, that after Jerry died, I had bereavement, but not melancholy. There was no loss of self-esteem. I was finishing up books and giving lectures. But I also had friends and lots of children, but most people don't have those kinds of supports. And there, I think psychiatry can be very helpful.
It's also talking to families, because there is the question, when a person is dying, the preparation of the family for it. When my wife died, not a single doctor ever sat down with me and talked to me about the disease. It was a doctor friend who had nothing to do with it who said, nobody ever survives carcinomatous meningitis. You better get yourself prepared. I was extremely grateful to that person. Still am, 8 years later, because that was a very useful thing for me.
One constant flow. Loss after loss.
Obviously, grief and bereavement and retirement are not the only psychosocial stressors. There are cultural issues, gender problems, and family issues, reinforcing the concept of how difficult the entire process of treatment planning can be.
I think treatment planning also depends on where the treatment's occurring. I think the treatment plan that you establish in a hospital might be different from the one you establish in a partial hospital versus one that you establish in an ongoing outpatient relationship. I think just by virtue of what's happening in the healthcare sector, I think inpatient treatment planning should focus on acute symptoms, pharmacology, drug education, what's the course of the illness, you have to stay on the drug, these types of issues. I think in the hospital you identify the interpersonal issues, the psychological issues. The fact is you may be able to make it started, but I think those issues then get carried over into partial and further outpatient treatment. I think some of our colleagues run into problems is because they confuse the two, and then that's where they start.
How do you make the decision to put the patient in the hospital?
Well, I think we are forced to consider only 3 or 4 things. The patient is suicidal, the patient is agitated, confused, or the patient has failed to respond on an outpatient basis.
One more is common is refusal to eat. So they're just wasting away because they're not eating.
Also, inability to care for the self, I think, would be another indication of hospitalization.
And one more factor is the nature of the social support system. That person who's totally isolated without a social support system is a much higher risk for suicide.
I think another really important risk factor that frequently gets overlooked is the whole issue of hopelessness. And Beck's studies here at Penn were very influential in my thinking, because he makes the point, and I found this just over and over again in my own practice, is that the biologic signs tend to remit before the cognitive signs. One of the principal cognitive signs is hopelessness, so while the patient is sleeping and eating better and looks more energized, they in fact still have this pervasive sense of hopelessness. And that's one of the clues I constantly look for in my patients, even as when they're, quote, better, I'm looking is there still some residual hopelessness, because I think that is still an underappreciated risk factor.
Yeah, I feel much better. Yeah. Last week I visited my brother's grave.
That you might call that pseudo flight into health. Yeah. But my question really is, since the vast majority of people who look better are getting better, how do you pick out the ones who are fleeing into health or are going to kill themselves?
The first time I had a patient who successfully killed herself was when I was a resident and didn't understand the concept of the flight into health. And what that hospitalization did was gave her the energy to go out and be lethal. And I guess the same thing is true of anxiety. You feel that you've got a more anxious patient than a depressed patient, and your sense is it's not really a risk, and so you don't put them in the hospital, and you essentially treat them as an anxiety patient, missing the depressive symptoms. And I think that's why it's so critical to be careful about the symptomatology. Yes, Bill?
I think the other reality of it is, in a patient who's determined to kill themselves or is going to do so. Years ago, I had a woman who was in her 60s who I treated for depression. For all intents and purposes, she looked well. All her symptoms had remitted. The family said, "Do you think we should have someone stay with her for a couple of weeks?" Because I said, "Fine, I think that would be a good idea. She lives alone." The first 2 weeks after discharge, she did fine. And then one evening, the woman who was staying with her goes to put the garbage in the hall. And when she walks outside, the patient locks the door, then goes to her room, puts her jewelry on the table, takes her shoes off, and then jumps 17 stories out the window. So I think that with a determined patient, despite our best intentions and interventions, we can't stop them.
The other thing that I've been impressed with in my own practice is the clear family history of a parent suiciding.
I think that's the strongest.
To me, that's really sent chills up my spine when I get that history. I've got somebody sitting in my office and they're morbidly depressed and they're not having active suicidal ideation that they admit to, but they're clearly depressed, and the history is that my father killed myself at roughly the same age that I am now. I'm not going to sleep myself for the next 2 weeks when I hearing that kind of history.
You mean you're going to hospitalize the patient from your office?
I may very well, although of course in the present atmosphere, sometimes that's difficult to do, realistically.
So, inability to care for self, lack of social supports, suicidal intent, homicidal intent, any actions that are clearly negative in the sense that they would be hurtful to the person.
Confusion.
What a confusion. Does this fit with the current managed care? Are we forced to treat people outside that we should have inside?
Yes, and part of the difficulty is that there is sometimes a formulaic approach of whether the person has suicidal ideation or a suicidal plan. And sometimes the reviewer will say, well, is there a plan? And if there isn't, they can't get in the hospital. But what they don't take into account is a fair number of patients who are lethally suicidal will not talk about the plan because they don't want to be stopped. They want to carry it out, so they will not tell anybody, especially the psychiatrist. So that's where I've gotten into trouble with the managed care reviewers.
I think because we have a lot of doctors who are listening to this and could be stuck in this dilemma, my suggestion would be, in case of doubt, what I would do is hospitalize the patient.
I think you're safest when you follow the community standard of medical practice, no matter what the reviewer is telling you to do. And then, you might have to eat the cost occasionally of the hospitalization, but you're certainly on the safest ground when you document that you're following the community standard. I'll have a colleague sign a note in the chart agreeing with that, something like that.
I was just thinking of other indications. If there's comorbid alcohol or drug abuse, would that be another indication for hospitalization? Is that hard to manage on the outside?
Well, sometimes it is, although sometimes the managed care company wants to send the patient to a non-medical, non-psychiatric institution because they focus on the drug and alcohol and not on the depression. When we as a body politic of psychiatry think about treatment planning, we've got to have a clear picture of what we're going to do, starting with the role of the psychiatrist as the manager, the psychotherapeutic psychiatric manager. And we as a profession need to hang in to the best interests of the patient. And we've developed depressive guidelines. Some of you in the room have been participant in that. And I guess I'd like to get some feedback about your sense of how will that work, if at all.
The genesis behind these guidelines was that the other organizations, including the federal government and managed care organizations, are putting forth their own guidelines. The APA wanted to put itself on record, coming out with APA guidelines. In the process of creating these, we corresponded with hundreds of psychiatrists across the United States. And I think we produced a document that supports everything that Dr. Weissman has been saying about requirements for proper evaluation and treatment. We tried to be as specific as we could in our recommendations, and I think in reading them, I have found them to be vaguer and less specific than we had initially intentioned. And I would like people to understand that the reason for that is because it's very, very hard to make psychiatric treatment paradigmatic and to reduce treatment to an algorithm.
It's also difficult to reach consensus without making them vaguer. That doesn't mean they're bad. They are an essential statement of what we know about depression and how we view depression and what we can do for depression in the current atmosphere of our treatment modalities. I think, in a sense, they are as good as we could get.
I would agree with that. And after having put in so much work into preparing these, I would regard managed care's guidelines, if they are more specific than this, as being illegitimate, because this really represents the consensus of 1993 psychiatry.
I do think we come to a real important conclusion, and that is that there is no question that our role in psychotherapeutic management is key. we have to play that role, whether we delegate pieces of the care to non-psychiatrists. We cannot allow them to allow us to abrogate our role as managers. Ladies and gentlemen, I want to tell you that you've been terrific, that this has been outstanding. It's been a very, very exhilarating day and a lot of information. I've learned a lot. I think everybody in the room has learned a lot because we came with certain packages of information and we got augmented by our colleagues. So thank you very much and have a safe and good trip home. And
This is a lot more fun than I thought.
It's probably, I would think, the